Go.
Good evening. Greetings from Calicut ONG Society. Today is the second session of our monthly webinar, which is held on the second Saturday of every month. Before I welcome, let's have the blessings of God by a short prayer. Venu, one prayer, please.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. May the blessings eradicate the corona from our lives. So with this, I perform my duty of welcoming. At the onset, I welcome our guest of honor who will be joining us around 7 p.m., Professor Paili. He is a pioneer in APH and has devised so many procedures and instruments. And today we'll be watching the videos he would be going to us on management of APH and placenta accreta especially. Next, I welcome our chairpersons, Professor Shekran, who is the pillar of Calicut ONG Society, and Professor Kellamma. Both of them have great contributions for this PG teaching webinar. I welcome you, sir. I welcome you, ma'am. Next, I would like to welcome the faculty of the first session on placenta previa, Professor Kunjamma madam, from former Professor and HOD from KMC Medical College, Kottayam. Now she is working in Believers Church Medical College, Tiruvalla. And I'm happy to inform you that she has done maximum number of obstetric hysterectomy using the aorta clamp. Welcome you, ma'am. Next, our guest, Professor Brigadier Anna Menon, who is an alumnus of Calicut Medical College, 24th batch. She's an ardent teacher and I've heard her at ICOG webinars also. Welcome, ma'am. Welcome for your contribution for our webinar.
Thank you.
Next, I would like to welcome the faculty for a second session of Abruptio Placentae, Professor Lalitambika madam, who was Professor and HOD from Government Medical College, Alapura, and Professor K. Ambujam, who is Professor and HOD from Medical College, Thrissur. I know both of them have got great contributions for our Kerala Federation and lots of experiences in dealing with APH. Welcome, ma'am. Next, I welcome our office bearers, Dr. Subhash, Dr. Rajesh, Mehta, and all who have logged in. I welcome the Sun Pharma. I welcome our junior residents from Medical College, Alapura, and Medical College, Thrissur, and KMCT Medical College, who will be joining in case discussion. And last but not the least, I'm happy to know that the postgraduates are benefiting from our monthly webinar because we have lots of logins, and Facebook also, they are, it's live streaming. I'm very happy to be part of this endeavor. Thank you. Next, I request Professor Shekran to introduce Professor Kunjamma Roy, and then we can start off, followed by Chellamma madam. I think Subhash can introduce.
Chellamma madam is there, ma'am. Chellamma madam is there. Sapan, can you please upgrade Chellamma madam as a panelist?
Can introduce Kunjamma madam. For CV of Kunjamma madam, please.
Okay, I think.
Good evening, friends. Professor Kunyama Roy was here at Calicut also earlier, and later on she moved on to Calicut Kottayam Medical College, where she retired as the professor and head of the department. Now she is at Tiruvalla. Now, more than that teaching career, planning for a long time and teaching many postgraduates and undergraduates, she was also our president of the Kerala Federation and contributed very much to the activities of the Federation at that time. And very quiet person, but doing things very accurately, very sincerely. And she is the person who has done probably the maximum number of obstetric hysterectomies, especially in placenta accreta syndrome or spectrum disorders. At that time, we were having some maternal loss due to this condition, but she has done many cases successfully, especially using Dr. Piley's clamps and other. We were all scared at that time whether to clamp the common iliac or aortic clamp and other things, but she has done it and improved the care of this very dangerous condition, placenta accreta spectrum. We lost initially 7-8 mothers in the initial phase of it. And then we had the plan, and thank you, Dr. Kunyama, for ironing out that procedure of treating such patients. And I think the students are very much lucky to have such experienced teachers for this session. So welcome, Dr. Kunyama, and thank you very much.
Thank you, sir.
Chellama Madam there, Subhash? Subhash can.
Yeah, ma'am. Chellama ma'am is actually there, ma'am, but then she's not been upgraded yet. She's there as a attendee list. Sapan, Venu, somebody, can you please upgrade Madam, Chellama Madam?
Yes, it is already.
Not as terrible as the usual typhoids that we have. Madam is Professor HOD KMCT Medical College. Yeah. Officials at Calicut, also president of Kerala Federation of ONG. She was secretary IMS Calicut chapter. She has lots of publications for her on her credit. Madam, please introduce Dr. Aruna Menon, Brigadier Aruna Menon, to the audience. Has she logged in?
Venu, please promote Dr. Chellama, madam. We can see still she is there in the attendees list.
Yeah, I think there's been some technical glitch here. So in the meantime, has it been done?
Yes, it is. It is done.
Yeah, right. Thank you. Chellama Madam. Yeah, I think.
Please project the CV of Brigadier Aruna Menon.
Dr. Chellama is there. Unmute, please, Chellama.
Something wrong with the screen?
Ma'am, Aruna ma'am, presentation, it's unvisible. Is this visible? It's not visible.
Yeah, it's visible.
There is some shade over that. And the technical side, there is
just
some
a minute, madam.
disturbance.
Yeah, I'm talking to him. Just a minute. I'm talking to him.
Okay.
I'll send you. Kishore, I'm sending
May
you.
I?
Hello. Okay. Madam is there. Okay.
Yeah.
Hello.
Yes, ma'am.
Yes,
Please
madam, we can hear you. Please introduce Brigadier Aruna Menon to the audience.
Okay. So good evening to all of you. I'm very happy to introduce Brigadier Dr. Aruna Menon, and I know that she is the alumni of Calicut Medical College. Very nice to see you, Dr. Aruna. And she is the alumni of AFMC Pune and the University First Rank holder and from Pune University for MD. And also now currently the professor and HOD at AFMC Pune. And he had so many international papers and also her areas of interest are gynecology, high-risk obstetrics, and hobbies are blogging, writing, especially publications for this. Welcome, Dr. Brigadier Aruna Menon, to this webinar, especially teaching program. We know that you are a good teacher.
Thank you.
Very nice to see you.
Thank you so much.
Thank you, Madam Chellamma. Now we start with the case presentation. The first case presentation is on placenta previa, and the present case is Dr. Aparna from Medical College, Alappuzha. Aparna, please share the screen. The faculties, the floor is yours.
Thank you, madam.
Please share the screen.
Good evening, madams. So this is a case presentation on placenta previa.
Just a minute, madam. Mr. Venu sharing again.
Okay.
Sure, remove the notification box.
Yeah, some issue with the PPT. Anyway, it's shared.
Okay. Good evening. So this is a case on placenta previa. I'm starting with the case. A 29-year-old Mrs. X, she has studied in 12th standard and she is a homemaker. She is hailing from Alappuzha and belongs to the lower socioeconomic class. She is married to Mr. Y and he has studied till 10th standard and he is working as a driver. He has an obstetric score of GCP1 L1A1, that is previous one full-term cesarean delivery and one previous miscarriage. Her last menstrual period was on September 28th and her expected date of confinement on July 5th.
There's some disturbance on the audio.
That is from the technical side.
Yeah, I think they should mute themselves. Yeah, fine.
Okay, right, carry on.
Okay, madam. As on the day of taking the case was 36 weeks and 2 days. Her blood group is B positive. Can you change the slide? She was admitted at 36 weeks of gestation for safe confinement. History of present pregnancy. She is a book case in TDMC Vandanam. Her first trimester.
Next slide, please.
It was a spontaneous conception. It was not a planned pregnancy. The pregnancy was detected by UPT. Pregnancy was detected by UPT 1 week after missing periods. Her first ANC was at 8 weeks of gestation. Folic acid was taken and routine blood and urine investigations were also done and all were found to be within normal limits. Dating scan was done at 8th week and the dates were corresponding. Previous 3 cycles were regular. NT scan was done at 12 weeks and it was said to be normal. And there was no history of any spotting per vagina, urinary tract infection, radiation exposure, or any other drug intake or hyperemesis. Second trimester, also she had regular ANC. That means she had 3 ANCs in the second trimester. She appreciated quickening at 5th month and was started on iron and calcium supplementation. 2 doses of TT was also taken. Her blood sugars were monitored. 75 gram DTT was done and it was found to be normal. There were no history of any high BP recordings. And during the second trimester also, she had no history of any bleeding or spotting PV. Anomaly scan was done at 20 weeks. No anomalies were detected for the baby, but placenta was said to be covering the internal loss. And She was advised avoidance of strenuous physical activities. In third trimester, she had regular ANC. She was appreciating good fetal movements during the third trimester also. She had a growth scan at 30 weeks, and the growth was said to be corresponding. Here also, the placenta was said to be covering the internal os. No other abnormalities were detected in the scan. Blood sugars were monitored, and they were within normal limits, and there were no history of any high BP recordings, and no history of any bleeding or leaking TB in the third trimester. And she was advised to have an elective admission at 36 days for safe confinement. Past medical and surgical history. There was no history of diabetes mellitus, hypertension, liver, renal disease, bronchial asthma, tuberculosis, thyroid disease or cardiac disease. There were no history of any blood transfusions and no history of any drug allergy. There were no history of any abdominal surgeries other than cesarean section. Menstrual history, the menarche was at 14 years. He had regular cycles of 30 days duration, and all previous 3 cycles were regular. And her last menstrual period was on September 20. He has been married for 7 years, and it is a non-consanguineous marriage, and there was no history of any infertility treatment. Past obstetric history. The first conception was a spontaneous conception 1 year after marriage. It had no antepartum complications. She gives no history of any abnormal placentation in the first pregnancy. IOL was done with PG even. It was an on-date induction, and she delivered a female baby at weight 2.7 kg. She's 5 years old now. It was a full-term cesarean delivery in view of failed induction, and there was no history of any intra-op or post-operative complications. She underwent a copper-T insertion 1 year after the first pregnancy, and she conceived with copper-T in situ, but it underwent a spontaneous miscarriage at 2.5 months of gestation. She presented with bleeding TB, products protruding, following which evacuation was done. In family history, no history of diabetes, hypertension, cardiac disease, or seizure disorder in the family. No history of any intrauterine fetal demise or twinning in the family. Personal history, she enjoys a non-vegetarian diet. She has normal bowel and bladder habits. Sleep and appetite is also normal, and she has no history of any addiction. Socioeconomic history, she has studied till 12th standard. She is a homemaker. Husband is the breadwinner of the family. He's working as a driver, and they belong to a BPL family. Coming to general examination, she's well nourished. She's having a height of 160 centimeter with a weight of pre-pregnancy weight of 56 kilogram, BMI 21.87. Her present weight is 64 kg. She has no pallor, rectus cyanosis, clubbing, lymphadenopathy, or fetal edema. Plus thyroid, spinal gait also were found to be normal. Her vitals, pulse rate is 72 per minute, which is regular rhythm and normal volume. BP 110/70, which is recorded in the right upper limb in sitting position. Respiratory rate 14 per minute. The cardiovascular system, JVP was not elevated, S1, S2 was heard normally, and no murmurs were there. Respiratory system, air entry was equal bilaterally, and normal vesicular breakdown, there was no added flow. Central nervous system, higher mental functions were found to be normal, and no focal neurological deficits were there. Next, coming to the obstetric examination. First, the inspection. Abdomen was found to be longitudinally distended. Linea nigra and stria gravidarum was present. Umbilicus central and everted. Lower segment Caesarean scar was seen. No visible sinuses, dilated veins seen, and the hernial orifices were free. Palpation. The fundal height corresponds to 36 weeks, which was corresponding to the period of gestation. Symphysial fundal height was 34 centimeter. The fundal grip showed a soft, broad, non-palatable mass, which is suggestive of breech. In umbilical grip, a uniform curve resistance was felt on the left side, which is suggestive of fetal back, and irregular limbers were felt on the right side. First pelvic grip, a hard, brown, compact, palatable mass, suggestive of fetal head, was seen at the lower pole. Was felt at the lower pole, and it was mobile. Second pelvic grip, confirming the first findings of the first pelvic grip, and inciput was found to be at a higher level than the occiput, which is well flexed. Head not engaged, and LICA was adequate clinically, and the estimated fetal weight clinically was 4.8 kg. Auscultation, fetal heart sounds were heard well at the left spino-umbilical level, and the rate was 132 per minute. To summarize, it is a 29-year-old multigravida with history of 1 cesarean delivery and 1 spontaneous miscarriage with excellent dates. She was accepted at gestational age 36 weeks, 2 days with no known medical or surgical comorbidities for safe confinement. On examination, she had a single live intrauterine gestation with corresponding growth, cephalic presentation, with well-flexed and mobile head, complicated with ultrasound suggestive of placenta previa. Diagnosis: 29-year-old G3P1 L1A1 with a gestational age 36 weeks 2 days, singleton fetus in cephalic presentation, complicated by placenta previa.
Shall we start question?
Yes, madam.
Dr. Aruna, do you want to start? No, please go ahead. I'll follow you, no problem. In the presentation, after listening to the history, my first question is there any risk factors in this particular lady to have this placenta previa? Second question is, since you know that she has placenta previa, what is your major concern? What you have to consider more than simply believing some finding of some other person? So please answer the first question.
So first of all, madam, first question, can you repeat once again, madam?
The risk factors in this particular patient, she is G3P1L1, 1 abortion miscarriage,
yes,
DND done, and that too with coppeting.
Yes, madam.
And 1 cesarean section.
Yes, she has 1 history of cesarean section, which increases the risk of placenta previa.
Is there any post-op complications following that cesarean, like puerperal sepsis or anything which may weaken the scar? Nothing is there.
She said there was no history, no complications.
Okay.
Madam, I lost connection. I was not able to hear what you said.
Okay, you proceed. See, now you know that she has placenta previa. When was the last scan done to confirm it?
The last scan was done just 3 days back prior to admission.
Oh. Then also it is covering those.
Yeah, it was covering the use.
See, what is your major concern now?
She might go into labor, and if she's going to develop an abdominal pain, then she might bleed, and this will result in an antipart, and we will have to go for an emergency cesarean section then.
Okay. Suppose you are the obstetrician who performs phonology or transvaginal ultrasound in the first trimester at 8 weeks. What are the findings you specifically look for with the history of this particular patient? Like, 1 miscarriage, evacuation done, 1 cesarean section.
Yes. So in the early scan itself, we will look for any features of any accreta, any placenta accreta, because she is already having 1 cesarean section.
What will be the findings that will point towards that suspicion?
If there is an accreta, there will be loss of the retroplacental sonolucent zone.
No, in the first trimester, 8 weeks, 8 or the first 12 weeks scan also she had. At that time, will you be able to at least suspect that this could be placenta previa or turning out to be placenta accreta, PAS, the placenta accreta syndrome?
Placenta
the findings you have to look
What
for.
are the early findings that you may see in a case of placenta previa, which may give you a clue that this may later on develop into a placenta previa? You mentioned both the ultrasounds, but you didn't really comment on the location of the placenta in either the, I think the first dating scan, of course you can't say, but at least they'll give you some clue. But you didn't comment on it at all.
Location of the gestational sac itself.
Location of the placenta and the gestational sac. Whether gestational sac is the placenta, whether it is where the placenta is developing, is it anteriorly or is it posteriorly? So if it is developing anteriorly, the chance of an accreta or an developing an accreta is more because it is
anteriorly in the lower segment. If it's in the upper segment, no problem. Anteriorly in the lower segment, near to the scar or onto the scar or into the scar. That has to be checked, especially in these days where the incidence of placenta accreta syndrome is very high. We have to look into that findings.
Maybe it was there and you haven't mentioned it. Are you aware whether it was any comment about the placenta was given at that time?
No, just the placenta
If you
was
have the
developing
documents with you?
Not right now, but from what I remember, what they have mentioned is placenta is developing posteriorly in the lower segment. That's all it is mentioned. They are not developed. They have not mentioned anything further.
Okay, but when you have a case with a previous cesarean, maybe you can also ask for it. Even if the radiologist hasn't mentioned it, you can specifically ask for it, isn't it? And especially after that, in the second trimester also, when they mentioned that it is covering the os, you could have again, I mean, there was no comment about the accreta or whether there was accreta or not. You just mentioned that it was covering the os. But that is the time when you should look for that as well, isn't it? And again, after that, at 28 weeks, when you finally confirm that it was placenta previa, again, that is the time when you should know whether there is any consequence or any problem of accreta or not, isn't it? Ma'am, can I go now?
Yeah.
A few questions about the history I wanted to ask you, Dr. Aparna.
Yes, madam.
You said that her husband is a driver, isn't
yes,
it?
Yes.
So
Yeah.
do you classify them according to any particular scale? Any?
Yes, madam. The modified Kuppusamy scale has to be used for classification.
So well, especially when you're presenting in this kind of a forum, maybe you could mention that, isn't it?
Yeah,
and even now, if you think about it, which class do you think she belongs to?
I think she belongs to class 3.
It actually takes a little bit of calculation.
Yes.
How do you do that? Do you know how to do that?
We have to consider 3 things. One is about who is the education, who is the major breadwinner of the family, and what is the income of the breadwinner.
Yeah. So in such a forum, or even when you're presenting at the exam, it is good for you to mention that. Okay. Now, coming to your examination, you said, can we have the inspection slide again? You said she's got a LSCS scar.
Yeah.
What is that scar?
I was also planning.
Can you see an LSCS scar?
I mean, no, over the scar over the skin only.
Yes.
Not the uterine scar.
So it's important for you to describe it correctly, isn't it?
Okay.
So what you see is a fan and steel scar, isn't it?
Yes,
it may be anything inside. We have no idea. And even now, we don't know whether it is a vertical scar or a fan and steel scar because you didn't mention it. So you must mention that. Anything else in the examination that you must tell us regarding the scar?
The scar over the lower segment, what is the length of the scar? Is there
Again,
any,
you're saying lower segment. You cannot see that scar. Lower segment scar is inside in the uterus, isn't it?
Nice.
So you can't see it right now. You can only see the scar on the abdominal wall. But can you look for anything else? When you say that she's not just placenta previa, she also has previous cesarean. So what is the other thing that you must look for and mention it when you are presenting? If she wasn't placenta previa, I mean, you shouldn't be blinded, no? She is also a post-cesarean patient. Wouldn't you look for scar tenderness any other time? You should mention it in your examination finding, right? Okay. Okay. How do you measure the symphysiofundal height? You said the symphysiofundal height is, I mean, I've forgotten the exact figure.
34 centimeters.
Okay. How do you measure it?
So first of all, we will ask the patient to lie in the, first of all, we have to make the patient lie down and with the knee and hips semi-flexed. And we are after emptying the bladder. And then with our, we have to palpate the symphysis pubis.
Okay.
Then correct the dextro rotation. Then by using the tape measure, we have to keep it so that the inches side is on our side and the centimeter side is on the opposite. The centimeter side is on our side, the inches is...
what you said was right.
Yeah.
So it should always be the other way. You shouldn't be able to see what you're measuring. No?
Yeah, to avoid bias. And then we have to palpate from the sternum downwards with our hand. And then I identify the fundus of the uterus, and we have to place the tape from the symphysis pubis to the height that you have identified.
Why are you doing that? Why do you measure it? Why can't you measure it the other way, from the fundus to the symphysis pubis?
Symphysis pubis is a fixed point. So,
Okay, good. Yeah. What about the abdominal girth? How do you measure it?
Abdominal girth is measured at the level of the umbilicus.
In inches or in centimeters?
In centimeters.
Right.
First, we have to identify in inches and then measure it in centimeters.
Abdominal girth is always in inches. But so I can't ask you the next question. Why in inches? Dr. Jyoti, I think you have other residents also. Will they be answering?
Yes, you can.
Yes,
Maybe somebody else can take the question.
Shamima, Hridaya, please answer. You can also join.
Shamina, please unmute.
Yeah, she
corresponds to the gestational age.
Yeah. Corresponds to gestational age in
inches, ma'am.
Yeah. So it's always, the SFH is always in centimeters and the abdominal girth is always in inches. Okay, because that is how you're supposed to do the measurement. Okay.
Okay, in the physical, in the history, I want to ask one. In the history, I think she was advised to restrict physical activity. Actually, she belongs to a social class that is not much educated. So you have to be very specific. Physical activity, what way? Because in the placenta covering the os, what sort of physical activity, even the sexual activity, that also, even like, you know, not only the intercourse, but any sort of sexual activity which will increase the, or which will produce orgasm, that can cause uterine contraction and can cause bleeding. So you have to be very specific in such things. No? Instead of simply saying that restrict physical activity, she may do less work, household job, but the other things also you should explain to them. And the next thing I would like to ask regarding this case is, since this is a previous cesarean with a history of miscarriage, dilatation, and evacuation, then all the risk factors are there even for placenta accreta spectrum. For the problem of PAS, that has to be considered, and what will be the findings to say that that is excluded, or you are doubting it? Because sometimes, no, even with a scan of placenta previa alone, when we open for a cesarean section, accurately we may find it as placenta accreta spectrum. So you should be like, no, well equipped or well experienced to deal with that situation. So what you have to do to find out or to exclude placenta accreta spectrum, and what are precautions you have to take when you are planning the management? If you want to answer these questions later, or if Dr. Aruna want to ask anything before that,
that's fine. I just had one other question. Let her answer this. I'll carry on after that. No problem.
But because of the time shortage, the management part should also be included.
Please go ahead, Doctor.
Yeah. So in order to exclude a placenta accreta,
other people also, no? The two more PGs are there. They can
Dr.
also
Shamima
answer.
and Dr. Hridaya.
Yeah. You can also answer.
Yes, ma'am. To rule out placenta accreta spectrum, we have to request the radiologist. In NT scan, in this case, the patient has the placenta covering the internal os. She is having history of previous years and a history of dilatation and evacuation. So we specifically request the radiologist with the history to rule out placenta accreta spectrum. And
how do you exclude?
There are so
if
many
you had to
features
look for it, what would you look for?
Okay, in ultrasound 2D scan, there will be absence of the translucent zone behind the placental bed. Then there will be thinning of the myometrium between the placenta and the bladder. Then loss of bladder brightening line between the placenta and the bladder. There is bulging of the...
Any other modality you can use to help you when you're doing the scan?
Before that, a few more findings are there, no? Before applying the color Doppler, what other findings?
Bulging of the
placental lacunae, multiple placental lacunae. That's the first thing you see.
Okay, lots of lacunae, placental lacunae will be there with the turbulent flow. Then the bulging of the serosa into the bladder, and sometimes there will be protrusions into the bladder. That is, the placenta will pierce the serosa, and exophytic growths will be seen in the bladder. Then with the Doppler scan, we can see hypervascularity in the utrovesical bed. Then there will be hypervascularity in the placenta. Then there will be feeder vessels into this lacunae from the placenta. Then there will be bridging vessels from the placenta into the adjacent structures. This will be the findings in ultrasound and the Doppler.
Okay. So I think we can go on to the management then. So she's now 36 weeks. When are you planning to terminate, Dr. Aparna?
If there are no features of any accreta, if the accreta has been properly rolled out.
We've discussed accreta now.
Yeah. So we can terminate at 37 weeks. Better not to go beyond 37 weeks.
37. Okay. Any other views? Dr. Hridaya and Dr. Shamima?
It is better to terminate it at 36 weeks. 36 to 38 weeks.
Wide range.
I know. So,
if there is no history of bleeding and continuing as asymptomatic, you can go up to 37 weeks. No?
37 weeks. No?
Yeah.
Let us see. Okay, now you have to take her up tomorrow for cesarean. What all will you do today?
Yeah. First of all, we have to allot the blood bank regarding the need. We have to we have to arrange for at least 4 pint PRC, and we have to keep it cross-matched and ready for tomorrow. We have to explain to the patient the need. Sometimes there might be a need for a hysterectomy also. So a written informed consent has to be taken from the patient regarding that. Then for the local preparation and pre-operative and medications has to be given in the night itself.
What are you following in your institution? Are you following ERAS or what is ERAS?
ERAS is minimally
E, starting with E.
Yes, Dr. Hridaya, you have not said anything. You can attempt the question.
No? Early recovery after cesarean section.
After?
Surgery. Early recovery after surgery.
So are you following that or not?
Yes, ma'am.
So then, Dr. Aparna, are you following it? No. What do you do in ERAS? What is the difference between the traditional teaching and ERAS for cesarean also? What is the difference between the two? How will you prepare?
We have to ambulate the patient at the earliest. Then we have to start on oral.
We're talking about the pre-op.
A pre-op. We have to prepare the bowel properly. Then proper hydration of the patient before surgery.
What is the difference between, normally what do we say? We say nil by mouth after so-and-so time till the next day morning, right?
Yes, ma'am.
Any difference in ERAS and in this traditional teaching that you do?
4 hours NPO is recommended in ERAS. Then spirometry, preoperative spirometry is recommended. Then
till when will you give anything by mouth?
Yes.
You can actually do a carbohydrate load, isn't it? So that you don't allow them to fast for such a long period. We do that for the other surgeries as well as cesarean. Okay. Now, what problems will you encounter, or what are you anticipating the next day when you're doing the cesarean? What are you anticipating, and how will you prepare yourself for it?
During cesarean, there can be during the cesarean section, there can be difficulty in delivering the baby, as the placenta might be is covering the os. So
much before we reach the baby. She is also post cesarean, right?
Yes.
What will be? How will you plan your incision? Start from there. What incision do you prefer?
Here I plan to put a fan and steel incision, as there is only one previous cesarean section.
Okay. Any advantages for going vertical?
It is an easier
I agree with you. It's your choice. But is there any reasons if you want to go? Someone wants to do it vertically. Is there any reason?
Yes. If you are going vertical, then there is a easier access, quicker entry, and another important thing is even if at all it is going for a hysterectomy or a major operation, then vertical incision is preferred.
And especially if there is any suspicion of an accreta. So in this patient, that is not there. But if any of those suspicions are there, then you would prefer doing that. Now, how will you enter the, before you enter the uterus, anything else you look for? You open the abdomen, you said you were doing a phalansteal incision. What next?
Then we have to dissect through the layers of the abdomen.
Layers of?
Layers of the anterior abdominal wall.
You've already opened the abdomen. You're inside now.
Okay. Any adhesions has to be ligated and it has to be cut. Then on opening the uterus, we can look for any, you can look at the bladder if there is any invasion into the bladder or any purplish spots.
What is one of the most common things that you will find on the lower segment in a case of placenta previa? Yes, Dr. Shamima?
UV fold of peritoneum will be deep.
Increased vascularity.
Yeah. So you may even find engorged vessels across, especially running across your, if they're running across your planned incision line. So anything you can do that time? You want to minimize blood loss, right? So what will you like to do? Will you just cut through those vessels or is there anything else you can do?
Put a lower segment vertical.
If we anticipate heavy bleeding, we have to ligate the uterine artery prior.
No, uterine,
not before you do the cesarean, no? You may
have to ligate the vessels,
right? So that you don't lose blood when you're incising the uterus, right? And that's very useful. If you can ligate it both above and below the, those huge vessels, you can just undermine them and ligate it. So that minimizes the blood loss and your view is much better when you're entering the uterus. Okay.
When you open the uterus.
So if the placenta is overlying the incision, then you might have to cut through the placenta in order to deliver the baby. So after cutting to the placenta, you have to deliver the baby quickly in order to prevent any fetal compromise.
So in your case, it is placenta is completely covering those. So anteriorly, if you go a little above that edge, without injuring the placenta or cutting the placenta, you will be able to deliver, rupture the membrane and deliver the baby. As soon as possible, you have to try to avoid cutting the placenta because there is fetal blood is also lost and the baby may develop neonatal anemia. Okay. After delivering the baby, you are removing the placenta. There is bleeding from the placental side. What is the reason and how do you manage?
So first of all, when you're removing the placenta, if the placenta is not coming and if there is bleeding from the placental side, it can be due to an morbidly adherent placenta. It can be
placenta. We are discussing about the placenta previa now. There is no addition. Sorry,
you already removed the placenta.
Okay. So if you are able to remove the placenta, then if there is bleeding from the placental side, then there are certain things that we can do. So first of all, one thing is we can pack the lower segment with gauze and wait for some time in order to apply compression. Compression over the lower segment can be given in order to stop the bleeding.
Right in the beginning, by giving compression, our aim is to minimize the blood loss. No? She should not go for hypovolemia.
So first we have to give oxytocin and all the other oxytocin has to be given, and also we have to start crystalloids. 20 units of oxytocin can be given via infusion. And
what ma'am is asking you is, will you first give compression or will you try to stem that bleeding? And what can you do to minimize that bleeding? What she's asking.
Why there is more bleeding in the lower segment compared to upper segment placenta removal?
Lower segment is not able to contract because the placenta was implanted there. So
it's a segment of dilatation, not the retraction. No? Contraction and retraction is much less. So to reduce that bleeding, there are bleeding sinuses are there. Immediately, what you have to do?
We can put sutures. Sutures can be put.
Compression sutures. Or
what do you call those sutures?
Those sutures can be.
Figure of 8 sutures.
Pardon?
Figure of 8 sutures.
Yeah, so you can take sutures around that plus open the placental sinuses, and then it should not penetrate the cirrus of the uterus. You should include the destra as well as the part of myometrium, but should not come out. Okay. Any other method? So putting a different this square switches or pursuing switches around the bleeding points. What else?
Vasopressin
Like
injection.
balloon.
Vasopressin injection. Have you seen vasopressin injection, Divan?
No.
Theoretically, yes, but if it enters the circulation, that can produce cardiovascular and other problems. So vasopressin, of course, it is suggested, but it's not routinely used. Any other vessel ligation?
What are the other
Uterine
mechanisms?
artery ligation can be done.
What else?
Bilateral uterine artery ligation.
Any
Then,
other?
stepwise devascularization can be done by ligating the ovarian and uterine anastomosis. And then also
how is this supposed to help?
This will reduce the blood. This will reduce the blood flow to the uterus, and also it reduces the mean arterial pressure, and thus decreases the blood flow.
If that also fails, what you do? Your square sutures and stepwise devascularization also fails. Still bleeding continues.
Internal iliac artery ligation can be done as an endpoint, and if that also fails, then we have to go for a
before that, you can try compression sutures. No?
I think Dr. Shamima or somebody was saying. What are those sutures?
Compression sutures like Heyman sutures and Beeling sutures can be given.
How do you give
so simple
Beeling?
and easy, no? It is so simple and easy.
Yes, ma'am.
Any other method you can try because it is a bleeding from the lower segment. Before you go for compression sutures, any other
quantum tamponades and
yes, or the cribilone if available. That can also be tried. If that also fails, you go for compression sutures.
Anything else other than quantum tamponade? Anything else you can use?
Sengstake and black humor.
Pardon?
Sengstake and black humor tubes can be used.
Now there's a much better method, no?
Foley.
Anything else? Something that is used in it? Something that's related to the goat? Bakri balloon?
Bakri
mentioned it.
Have you used it?
No, ma'am.
No? It's a very, very useful thing to use, especially in these kind of, bleeding. How is it used? What do you do? Have you seen it? No? It's a very useful thing to have both in your labor room as well as your OT. It's good to get one. And like true Indians, we can reuse it. You can just do an ETO and reuse it. Though it's a little costly, but it's very, very useful. It's a very useful thing to have in your labor room or OT.
See, suppose this case, now you know that it's a previous cesarean, 36 weeks closed and placenta completely covered those. With that diagnosis, you have started your operation. But on opening, you find that all the findings are in favor of a PAS, placenta accretus improved. You are the junior person, or like no, you are not a consultant, but you have started in a peripheral hospital where there is not much facility to tackle with that. How do you manage? Suppose after your residency, you'll be going to the periphery.
You can close the uterine incision and ensure that the patient is hemodynamically stable and refer the patient to a tertiary center.
See, before opening the uterus, what will be the findings to tell you that it could be a placental accreta, placenta accreta, or increta or percreta?
There will be bluish. Macroscopically itself, you can see the placenta over the serosa. If it is an increta, if it is the percreta.
Percreta. Okay. In that case, what you do? Suppose the lower segment is bulging with the placenta and the myometrium is very thin and bluish or purple. And then the bladder is also like bulging like that. What you do? It was not diagnosed early. Somehow or other it was missed. If such a situation occurs, what you do?
I have to close the, either we can deliver the baby, but delivering the baby.
Which incision?
Anybody else?
Vertical incision can be put, and we can classical cesarean section incision can be put, and we can deliver the baby, then close the incision and refer her to a tertiary center.
See, suppose there are experts available in and around, what you do? Instead of transferring her to a higher hospital that is too far,
you can ask for help, no?
Yeah.
Till then you can wait after keeping a packed, then you can wait. Suppose such facility is also not there, what do you do then?
We have to close the
Because there
abdominal
were
incision.
instances like that, no? After opening only identifying it, then close the uterus and abdomen and then refer her, isn't it? But nowadays with the advent of all this 2D, 3D and MRI and all, it is very rare to miss the chance of PAS. No? But still, we may get, especially in the peripheral hospitals where not much of our facilities are not there, you have to keep in mind these possibilities as well. And suppose this is placenta percreta, what you do? Will you wait till this 37 weeks, as you said earlier, 36 to 38 weeks? When will you terminate? And what will be the finding right from the beginning? Because we don't have another piece of percreta. So nowadays the incidence is very high, no? Why the incidence is very high now?
Because of the increased number of cesarean sections.
Okay. Basically, what is the problem to cause this? What is the problem within the uterus?
There is a lack of the decidua basalis, and the trophoblastic cells are directly directly implanting into the myometrial cells with invasion through the serosa, and sometimes it is also invading the bladder serosa.
Basically, there is a damage to the endometrial myometrial interface. That is the main reason. That predisposes to the implantation at the scar or onto the scar or into the scar like that. And only in previous cesarean this will happen?
No, it can happen. It can even happen in a primary, very rare incidents, but it can happen.
In which are the situations where in a primary you can see, or they can occur this? They can have this placenta PAS.
And there is a history of endometritis.
Endometritis, yeah.
Asherman syndrome, or if she had a previous dilatation and curettage.
Or NTP or otherwise. Most important, this myomectomy. Enter into the cavity, myomectomy, even the upper segment, this placenta accreta spectrum can occur. So myomectomy, then submucous fibroid, adenomyosis, all these can predispose, but that's not common. But when a primary, if she presents with PAS, then you have to find out whether any such abnormality or pathology is there in the uterus, or any history of like hysteroscopic, separation of these adhesions, or any myomectomy done, or the detailed history should be asked for if it is even a primary or without a history of previous cesarean. Of course, previous cesarean, the cesarean scar is more prone to, but other conditions also can predispose to the development of this PAS. Okay, suppose you are the surgeon. How do you manage this PAS, placenta accreta? Placenta previa, we have already discussed, and you know how to manage.
Placenta accreta, so we have to admit the patient. If it is already diagnosed, we have to plan to.
When will you diagnose with confidence? When you can diagnose with confidence placenta accreta?
By 28 weeks to 30 weeks scan, we can diagnose.
Not at the time of anomaly scan?
Anomaly scan also, it is possible to identify, but we can confirm only at a later scan.
If all the findings which you have already mentioned is there at 20-week scan, it is there, then you need to, when will you want to do a repeat scan once you have diagnosed placenta accreta spectrum? 20-week scan.
28 weeks, we will repeat the scan.
And then, even 28 weeks scan will do.
And then again at 32 weeks, we have to repeat the scan.
Okay.
And if you are able to confirm the diagnosis, then we will plan an elective surgery at 34 to 35 weeks.
if asymptomatic, she can go to 36 weeks. Anyway, between 34 to 36 weeks, not later than 36 weeks. There again, as Dr. Aruna was asking, how do you prepare? You have to plan for the management well ahead.
So first of all, we have to ensure that our facility is able to tackle such a case. We should be able to, first of all, again, we have to keep blood arranged. And
first and foremost, you have to counsel the patient.
Yes, we have to counsel the patient regarding the need for a hysterectomy, and she won't be able to bear any more children. So, and also there will be chance for a bilateral ureteric injury as well as a bladder injury. So all that has to be explained to the patient.
Bowel also, yeah, best practice injury. He can develop fistula later, and ICU stay for sometimes even more than 2 days. That depends on the severity of the problem. So all these things we have to counsel her well ahead, and she should be mentally prepared for that.
There are some questions in the Q&A section where there's a little bit of confusion regarding the classification of placenta previa, because we have now changed the classification. So can anybody just, what is the difference between the old classification and the present classification?
Present classification, there is only two. There's placenta previa and low-lying placenta. If it is covering the os, it is said to be placenta previa. If it is less than 2 centimeters from the os, then it is a low-lying placenta. In placenta previa, both complete as well as partial placenta previa is coming under placenta previa.
So when do you say it's complete, and when do you say, can you say it for sure before the onset of labor?
Actually, a complete placenta, it can change later on because of dilatation and defacement.
So that is a bit of a, I think that is what the Dr. Jyoti just told me to, told us to have a look at the question and answer. And I think Dr. Jayaraman has asked about that. What is the moderator's view on the present classification? So I think the jury is still out, because I don't know why they changed it to this, none of us is going to wait till the patient goes into labor to decide whether it's complete or partial. So I think I would still go by the older classification, which is much more clearer for us and for the students to understand itself, where you say that when it covers the os, it is complete, and if it is away from the os, this 2 centimeter is not always. What are the fallacies? Why is there a problem in measuring this 2 centimeters, Dr. Hridaya? When you're doing an ultrasound, you can do it only on ultrasound, right?
Yes.
So what are the fallacies of ultrasound in placenta previa?
But in transabdominal sonography, we can't actually say how the centimeters of placenta from the os. We have to better depend on a transvaginal sonography.
Okay.
And using transvaginal sonography, we can say how the distance of the placenta from the os.
What are the fallacies? Where can you make mistakes? Yes, anybody else?
Madam, with a full bladder, there is chance for apposition of the anterior and posterior wall of the uterus. So it will give a false positive diagnosis.
So there is either an elongation of the cervix, or so you must be very careful when you're doing a placenta previa. You should be sure that she's on an empty bladder. And sometimes you may need to do a
transvaginal,
either transvaginal, or even have it confirmed by doing an MRI. Though it's not routinely used, but if there is a mismatch between two ultrasonologists or between you and what the radiologists find, then you may need to do an MRI, isn't it? Because sometimes it does surprise you, even on the table. Very often, I'm sure the more experienced gynecologists among us, we do get, sometimes a part of it may be just dipping into the lower segment, but it comes into your incision area. It may not be diagnosed earlier. So to avoid all that, it is good to have an MRI. I think we've sort of reached the end of the, Dr. Jyoti, do we have more time? You have more cases also?
2 more minutes are left, and somebody wants to know about use of vasopressin. Vasopressin in the lower segment, especially when it is placenta accreta.
Yes, vasopressin, that is advised, recommended by some, but not regularly used, because when you inject subendothelially, there is a possibility of vasopressin entering into the circulation.
There's so many open sinuses, and yeah, even I wouldn't prefer using vasopressin, though it has been recommended.
Some surgeons use it in dilution.
Yeah, only in dilution we use, no?
Yeah.
But still, anyway, we haven't used that, especially for placenta percreta. Pfizer is here, his clamps are here, so then there is no problem of excess bleeding. Then we can go ahead with applying the clamp and proceed with the hysterectomy. In case
Yes, the
of
next
quick
session
hemorrhage.
will make us understand.
One question, Dr. Aparna. What is the other MTP that we talk about? Not the MTP related to gynecologists, MTP in obstetrical hemorrhage?
MTP?
Massive
transfusion protocol.
So what do you say? When do you say that you need, it is a massive transfusion protocol?
When there is a blood loss of more than, massive transfusion is said to be happening when we are giving more than 4 packed blood cells within a period of 1 hour. Or you are replacing the lost blood volume. The entire blood volume is replaced within 24 hours. Then it is called as a massive transfusion. Massive transfusion protocol usually includes the use of both blood cells, fresh frozen plasma, cryoprecipitate, and fresh frozen plasma, cryoprecipitate, and platelet concentrate in varying.
Just tell me that again. What all will you give, and in what ratio?
Okay, the ratios are varying. So either you can give it as 1:1.
Ratios are not varying. It's all laid down. It's a protocol.
But 1:1 ratio is there for 1 pint RBC, 1 pint PRBC, 1 pint FFP, and 1 pint platelet concentrate. Or you can give it as
1:2 to 4.
1:4.
1:4. And will you give cryoprecipitate? Do you want to check anything before you cryoprecipitate? So you are doing lab investigations along with that.
Fibrinogen level has to be done before giving.
At what level?
If it is less than 150, then it is an indication for cryoprecipitate.
Okay.
I think Jyoti's time is over.
Yeah.
Okay.
I thank the faculty for the discussion, sir. Your opinion, sir.
And just one or two points. In a previous cesarean, we are always worried about the placenta previa and then accreta. So nowadays, the recommendation is even in the first trimester, when you are doing the aneuploidy screening, at that time, try to locate the placenta.
That's what I was saying.
You have to request for it. Then if it is there, when you are doing the anomaly scan, again look for it. Then if it is there, again you have to reconfirm it by 32 weeks. That is the recommendation now. Now by 32 weeks, it is still there. Then you have to look for whether there is accreta by Doppler and other things. And if it is showing as accreta, you have to plan your delivery by 34, 36 weeks. If the patient is asymptomatic, not at all having any bleeding, you can go up to 36. So here the candidate has told that she was admitted for safe delivery. Why do you admit at 36 weeks for safe delivery? She is admitted at 36 because of the placenta previa. So you have to put it correctly there. Safe confinement says at term, without any problem, at term you are admitting. Again, you can guarantee safe confinement there also. She is admitted for delivery. Then for the students, again, for the examination point of view, nothing much. In the management, they may even ask you triple P, like the MTP madam was telling. You should know all those, some of the points. For this, that will be surely asked, because some sort of question. So triple P and other things, you can look at it. So that's all. Okay, very well conducted, madam, Dr. Aruna Menon and Dr. Kunjama Roy. So I hope the students are having any doubt. You can, even though there is time is over, but still, if any student is having any clarification required, we can still accommodate that.
Or we can use the chat box, sir. I mean,
Okay, they can use the chat box.
And we can use the chat box.
Sure. The professors are here only, so you can clarify all your doubts. Doubt will be there once you have come prepared.
Chella madam, your comments?
Yeah. The discussion was very good, and both the examiners were very good in asking questions and extracting answers.
Yeah.
But one point I want to tell to the students that when you are presenting the case, especially your postgraduates, don't forget about the basic things. As Dr. Aruna has mentioned, in a case of previous cesarean section, you should look for the scar tenderness. I think in the case presentation, it is not mentioned. Nowadays, we are seeing a lot of cases of previous cesarean section, especially near term. You have to look for this scar tenderness in the previous cesarean section. And with the permission of the two examiners, can I ask two questions to the students?
Yes, ma'am.
Can always benefit.
Yes?
Yes, please, ma'am. Go ahead.
And the students, it is postgraduate students, they should know this, the advanced things. How will you classify placenta accreta spectrum?
Figo classification is there.
There is Figo has classified PIS. What is the classification?
That is grade 1, 2, and 3, and 3 can again be classified into 1, 2, 3 is further classified into again 3 classifications are there.
1, 2, and 3. What is 1, 2, and 3?
One is each classification there is a macroscopic finding as well as a histological finding. In first grade, it is placenta.
No, it's not histological. Figo says that if it is going into the myometrium, but the half of the myometrium, but it is not adherent. But the second one is it's adherent. And third one is it is going to us just like Percreta, but going into the organs, the pelvic vessels, and especially the bladder, etc. So that you should know, especially when in the exam, PG examination, you should know this. And another question is, what is triple P procedure?
Triple P procedure is followed for obstetric hysterectomy. For obstetric hysterectomy.
No, it is PIS.
For morbidly adherent placenta.
It is for conserving the uterus. It's a conservative.
That is a method of saving the uterus.
Okay, they will read it up. They will read it up. Of course, this is too stimulus to read. So you look at what is triple P or enhanced recovery after surgery. Madam was asking. We are not very much onto that practice, Madam Arina. Enhanced recovery after surgery is a very well educated thing, especially for long surgery, especially in placenta previa. You have to suspect. Enhanced recovery means nothing but patient is allowed to eat that to glucose containing liquid diet at least even prior to the operation.
Yes.
Then is allowed to eat immediately after the surgery, also allowed to walk around so that they go home well, not like starvation and rice tube and all those things are gone. And also the anemia and other things that is also cut.
Yes.
Also dehydrate the patient. So that is advanced recovery started in the colon cancer and then on to the gynecology side. And Madam, I think she is in the oncology side also. That's why the questions will come that way.
So we are following it for all surgeries.
And all surgeries advisable because here anesthetists say don't eat or anything. They will postpone the case if they have taken some liquid up for an hour. So they have to be also taken into.
They have to also be taken on board.
Yes. This is beneficial for the patient.
Yes.
Thank you, sir.
In the discussion that is, so those questions will come. Enhanced recovery after surgery. So that has to be put into practice. It is beneficial. Okay. So some of the questions you may not have anticipated has come up here. So please, this is the way very good. You are all passed, I think, very well.
Yes.
With the permission of the other two examiners.
Yes, sir. Yes, sir.
Okay.
Thank you very much.
Okay. Thank you, Dr. Aruna and Dr. Kunyama.
I am very proud that I can claim that my student is the examiner there. So I am very proud of you, madam. That is good.
Thank you.
Which year, Dr. Aruna, you studied here? Which year?
25th batch, ma'am. We passed out in 87.
87.
87.
We were that batch where the entrance exam ka problem was there, and then we. Silver Jubilee batch, yes.
Thank
you. I really enjoyed being here.
I think we will see you more often in our discussion.
Yes, no problem,
Dr. Jyoti, please see that she is with us more often than this.
Yes, he will be a regular.
I'm so happy to hear that. I'll be here anytime.
Very good.
I think Dr. Paili is waiting. So please introduce our guest of honor who's going to take a topic video. I think most of the queries are by his presentations.
Okay, that will be sure.
For introducing profiling.
Okay, I am to introduce Paisa.
Yes.
Okay. Okay, it's my great privilege to introduce Professor Paili, who was in the teaching faculty of Calicut Medical College and then later on as professor at Trichy Medical College. More than all those things, for Kerala obstetrics, he is everything. He started the first state conference way back in 1979. He started the Kerala Federation. He started the confidential review of maternal death in the state. This is the only state we are studying the confidential review of maternal deaths and finding the cause and trying to prevent it. And we are glad that we are below 30 per 100,000. So many things he has started. And also recently, because of the pandemic which is going on, he started another series of educating all of us about how to manage and reduce the death in COVID-positive pregnant women. So for us, Paili sir is Paili sir for all of us. And I think KFOG, I mean Kerala Obstetrics means Dr. Paili. To the topic concerned, he has his own contribution to the management of placenta accreta spectrum disorders. He has devised certain instruments and he has shown us how to do the surgery without a blood transfusion even required. So, Professor Paili, the students are to be very lucky, I will say. All those who are listening are lucky to have Professor Paili with us for this teaching session. So, welcome, Dr. Paili.
Hello.
Renu, please stop sharing.
Hello.
Yes, sir, we can hear you. Please stop sharing.
Okay. Thank you very much. Thank you, Shekhar-ji. That is a North Indian style, isn't it? Shekhar-ji.
But you always call me that way. You always call me that way. Oh, I am a classmate also.
That's the proud claim that we both have. Then, of course, Jyoti, Aruna, Kunjama Roy, and I think we see quite a few of you there. Thank you very much for this opportunity, mainly because it's always an entertainment not to be an examiner or an examinee and then watch and listen to what is happening, how the students get grilled and enjoy that. Maybe it's a sadistic pleasure, but the examiners today were so nice. Thank you, Kunjama and Aruna. I wish always examiners are like that, because very often the students are not allowed to even think because such a terror is in front, and so they may not be able to. So the smile that both of you showed, I'm sure would have encouraged the students to come out with answers, to keep the thinking process. And that is what I mean, Jyoti wanted me to say a few words before I go to the assigned job of showing you some videos. I think the examination, the usual problem is our thought process get blocked. To some extent, I should say that we examiners are responsible to some extent for that. And even otherwise, it's always adrenaline building up. The tension will naturally affect our thought process. But examination is a time where we, especially if you are listening to when others are answering, when we are able to learn a lot of things. Of course, examination at that time is not the time to teach somebody. That's the time to see how much you have been taught or how much you know. But anyway, my only suggestion to our students is that what I had always been telling the students who were going for the examination, please don't jam pack your brain the previous night. Leave it open. You have accumulated knowledge all through at least the postgraduate days. So if your thought process has to be searching and finding out answers, you should not be glued to, a brain which is jam-packed. Leave it free so that your thought process, what you have seen before. And the best way to answer a question that we have found is that see what would have happened in the practice, in the wards, where would have probably seen similar patients. What, when they ask you what preoperative preparation, we just think about what we do. Most of the time it should be right. There may be occasionally things expected of you which are not usually in the practice, but most of the time, even if you miss out something which is very extraordinary, they may not find fault with you. But the ordinary things we should not miss out. So pre-operative preparation, or if you are asked about IRAS, I know that it is not something which has been widely taken up across Kerala, something which we are too late, but I'm sure the ideas have come in and so soon we will take it up. But anyway, to the students, what I have to say is keep your thought process alive. Then only you can answer the questions. Then only you can find out the twists that sometimes examiners may bring in. And once you grab that and answer that, your credit points go up immediately. And at the end of the time that you have been given to answer questions, when the examiners sit around and think, how did she or he fare? These are the things, oh yes, she knew at least that much, like that. So my suggestion to only point to the examinees is keep your thought process alive when you are in front of the examiners. Coming to the topic that has been assigned to me, as Sharon sir said, we have been faced with this problem of accreta placenta or placenta accreta spectrum, as it is called now, for quite a while. In fact, it happened early this century in 2004-5, when we analyzed our maternal deaths. Then itself, it struck us that there have been patients dying on the table, not just the peripheral small hospital, in the teaching hospitals at that time, without having adequate blood for transfusion or because of excessive blood loss. On the table deaths. We are 4 and 5 numbers of deaths like that. And that made us think, why are they, in spite of having the best technique available, surgical skill available in our state, people were dying. So that is what made us look into the details as to what will be the problem, how we can overcome that. And we knew that the problem is because of the unmanageable bleeding that will happen when you are trying to do the case, when you are trying to separate the placenta. And that is what made us think of some methods to control the blood supply to the pelvis, to the placental site, to the bladder base, when we are trying to do a case like that. So can I share my screen, please? No, I think somebody may have to help me on this. Okay, no, sorry.
Yes, we can see, sir.
Can you see now?
Yes, sir.
Okay. So the first thing I thought I would show you is how to control the blood supply to the lower segment, because most of the time the unmanageable bleeding occurs at the bladder base or where we are trying to take care of the lower segment. And here, the method that we have developed is use this clamp, what we call the aorta clamp now, but to start with, it was called the common iliac artery clamp. I'm glad to share with you that it was actually at Kottayam, where Kunyama was, that we came to know that it would be better if you apply the clamp onto the lower end of the aorta rather than to the common iliac arteries. If you look at this, is the post-abdominal wall. This is the uterus, which is pushed out of the abdomen, anteriorly kept, so that we can see the post-abdominal wall. Here is the aorta here, and that's the right common iliac, and this is the left common iliac. Previously, we used to say that we could put the clamp, when we developed it, on the two common iliac arteries, on the pelvic brim. But inadvertently, I believe at Kottayam, they once happened to put the clamp at the lower end of the aorta and found that that is so much simpler. And now we have adopted that. So we are applying the clamp on the aorta, and the way to apply that is being shown here. You have to exteriorize the uterus, pack the bowels away, the sigmoid towards the left, small bowels towards the right. That will expose the sacral promontory. Above that, we can palpate. By palpation alone, we can feel the lower end of the aorta. And then as you can see here, having exposed the lower end of the aorta, with a Babcock, you pull up the lower end of the aorta. So make sure that you take the full thickness of the aorta and then clamp the Babcock, gently lift up that lower end of the aorta, and now bring the clamp, which we have specially developed for this purpose. You take it full thickness through, then take off the Babcock and palpate that to make sure that the pulsation of the common iliac has stopped. So this is how we have managed to control the blood supply that reaches the lower segment, placental base and all that. Because lower end of the aorta clamped means both the internal and the external iliac arteries are clamped. So the pelvic vessels are blocked, as well as even the vessels which go into the bladder, from where the bridging vessels, as the students were saying, come from the bladder surface towards the lower segment, and that also will get blocked. So that is the first thing to safeguard delivery of a placenta accreta spectrum. Now I may show you a real case where we actually can show you the steps, and that is, first what you are seeing now is we are passing the ureteric catheter. In patients where there is an percreta placenta, it's always better if you can outline the ureter easily when you come to clamp the uterine arteries and below. So what you are seeing here, a cystoscopy being done, and the ureteric catheter is being sent in. And the point I want to remind you, we do it ourselves. Very seldom only we call the urologist to come in. Either with a hysteroscope or a cystoscope, we put ureteric catheter rather than the stent to both ureteric catheters at the beginning before we start the incision itself. The advantage of this is we can palpate the ureter when we are putting the clamps onto the lower part of the uterus when you want to do a subtotal hysterectomy. So that is what you are seeing here. And the black rings that you see there will tell you how much of the ureteric catheter has gone in. Each line between the two lines is 5 centimeters. So if you see there are two lines close together, that means 10 centimeters has gone in. If the 3 rings close together, it is 15 centimeters, like that. So usually what we do is, as much as possible, you push in. But a practical tip again here is, you have to have when you put in the ureteric catheter, you should have a catheter guide. And catheter guide should go advanced, because the soft tip of that will not injure the ureter. Whereas if you just push in a ureteric catheter straight, it can cause perforation of the ureter. Now, having done that, the next step is we are putting an incision. And as was mentioned during the students' discussion, I think it was not highlighted much, but a vertical incision is always advantageous when you are planning to do a placenta accreta. You already know how low or high the placenta is. Your aim is to get the baby delivered without disturbing the placenta, which often may need that you have to put an incision on the fundus of the uterus. If you have already decided to do a hysterectomy, there is no harm even if you put an incision on the fundus or even the posterior surface of the uterus. Avoid incising the placenta. That is the important thing. And here I wanted to bring up a point that was mentioned by the students during the discussion, that a placenta previa, one of the students said that they will cut through the placenta. As far as I am concerned, that's a crime. You don't cut through the placenta. If you cut through the placenta, on the fetal surface of the placenta, I'm not talking about placenta accreta here, just because incidentally, because I heard what was being discussed, don't say that you will cut through the placenta whenever possible, unless it's a membranaceous placenta where it is so thin that you cannot go to the periphery of the placenta and get to the level of the membrane. In all other cases, you should try to push the placenta from the uterine wall and then go above that. Unless it is a morbidly adherent placenta where you incidentally happen to put your incision, then only you go through, because you cannot separate a morbidly adherent placenta like that. Otherwise, don't cut through the placenta. Anyway, here we are putting the incision on the fundus of the uterus, well above the level of the placenta. That is what you are seeing here. Through that incision, again, when you are incising, be careful that you don't go and injure the baby. And here, the breech of the baby was at the top, so we are delivering it. baby has been delivered and removed. So the cord is there. You can see that's the edge of the placenta here, but the other incision is over there. And then you are antiverting and exteriorizing the uterus there. And here, in this case, we are putting the clamp on the common iliac artery. We do put on the common iliac or on the aorta, depending on, for example, if you have inadvertently opened by a transverse abdominal incision and you cannot access the lower end of the aorta easily, you can put the clamps by displacing the uterus from one side to the other. You can put the clamp on the common iliac artery. But these days, if it's a planned case, we always prefer to put the clamp on the lower end of the aorta. You need not always see it. Sometimes you may even put it by palpation. When there is thick pad of fat on the aorta, you may not be always able to see the aorta cleanly as we showed you earlier. But remember, please, one more thing. The aortic clamp is applied without dissecting and isolating the aorta. The peritoneum on top of that is not removed. The fat on top of that is not removed. You clamp it with the fat and the peritoneum on the vessel and not after isolating the vessel. If you go to dissect there, that is the time when you are likely to get into trouble. Here, as we can see, we are putting the aorta clamp, and that we do on both sides. And if you are planning to do the same principle, Babcock to lift up and put the clamp. But if it's a common iliac artery, you have to take extra care that you don't clamp the ureter with it. And here, what you are seeing is another step that we used to do no more. That is putting a tunicate for the infundibulopelvic ligament. Here, that is the tube and the ovary in the fingers. This is the lateral end of the tube. So you take that feeding tube and take a sliding knot lateral to the end of the tube so that blood supply from the aorta through the ovarian artery, which supplies the uterus, the corner region, also will be taken care of both sides. But these days we don't do this because if you're planning to do a hysterectomy, put the clamps in the beginning itself on both sides. That will do the same work. And so we are not doing it like that anymore. Having got that sliding knot, we are showing you how to apply that. This will be a useful exercise even when you are planning to do a myomectomy. And you can see that is both infundibulopelvic as well as the aorta are clamped. And now we are doing the hysterectomy. Clamp cut at the top. Here, the round ligament with the tube is taken care of. And the next step you can see is coming down towards the uterine artery there. And here, this is the important thing. As you can see, the placenta is bulging outside of the uterus. And here you can see the thin layer of the peritoneum, which overlies the extruded placenta. And what is most important is you just get that peritoneum separated from there. And over here, that's the bladder. And when you come to the bladder, again, make sure that a sort of coagulum which is on the surface of the placenta is not disturbed. And I will show you more videos later on how to separate the placenta from the bladder, so you know. So here you can see that the placenta and lower down, that will be the bladder, is gently separated from the placenta. Here, that is the extruded placenta over there. That's the extruded placenta. We have gone to the level by palpation anteriorly and posteriorly, palpating anteriorly and posteriorly. We can palpate and mic out whether you have gone below the level of the placenta. Once you have reached that level, then you put the clamp across that cervix and do a subtotal hysterectomy. Subtotal hysterectomy and not a total hysterectomy. You want to emphasize this point again and again, especially for people who are from outside Kerala, because they all think that with a placenta previa, you have to do a total hysterectomy, otherwise there will be a problem. And even many people, many examiners insist on that. So if your examiner is insisting on that, don't argue with the examiner that you should not do a total hysterectomy. Please agree to what they are saying. But in practice, don't do a total hysterectomy when you say placenta previa or previa accreta or spectrum or percreta. Leave the lower end undilated part of the cervix there. That will make a better tissue to tie and take the mattress stitch rather than the vagina if you dissect that much. You can see here, we are double checking all the stumps, and then we'll get out to the abdomen after leaving a drain. And here, there's a specimen that we have removed. This is the incision through which we have taken the baby out. And here, the specimen is cut open just to show how the placenta is. So this is how we usually talk about a hysterectomy for these patients. Now, the most important difficult problem in a placenta accreta spectrum is when we are dealing with a percreta placenta. A percreta placenta that has come out of the uterus and invaded either the bladder or the parametrium. And the most tricky thing is when you try to separate the bladder from the, as you can see here, this is being shown here. Again, that is the extruded placenta. This Doyne's retractor shows that this is the caudal end of the patient. This is the extruded placenta over here. You see the color. It looks as though you are looking at the fetal surface of the placenta with appearance of vessels like that. These are not actually vessels like that. That is the coagulum on the surface or the maternal surface of the placenta. These are the vessels which are the treacherous ones. So when you want to separate them, you have to coagulate. In the triple P procedure that you were talking about, the aim is to take care of all the vessels which come towards the uterus from the anterior abdominal wall and from the bladder, so that in case you want to conserve the uterus, what we do is, after getting the bladder down below the level of the placenta, you can make an incision like that at the top end. You can make an incision at the lower end, remove the placenta with that part of the uterine wall, and then reconstruct the uterus. Anyway, let us see how we have to be careful when you try to remove the placenta after separating the bladder. And here, these are the vessels being shown. Those vessels have to be coagulated. And here, remember, this is the Doyle's retractor. So this is the foot end of the patient, and the bladder is being separated. And that is the most tricky thing. So easy to actually injure the bladder when you try to do that. So the clue I would suggest is, so the clue I would give you is, we should know the outline of the bladder. To do that, you should use the Foley bulb or the urinary catheter there. The urinary catheter Foley bulb can be brought up here, and that will give you an idea of the upper border of the bladder. And separate the bladder from the placenta after taking care of coagulating all this, gently, patiently separate it so that you don't make a hole into the bladder. If you make a hole into the bladder, then only you will realize how friable the whole tissue is. The opening that you make will immediately become bigger and bigger, and you will have a big cystotomy in your hand, and you have to then go to stitch that. Most of the time we do it ourselves, but if it's an unmanageable one, very rarely big incisions like that, then we may have to call the help of the urologist. So in the preparation for doing such a case, always have your urologist friend on standby. Tell them that in case I need your help, because we are going to do a case like that, it's better to warn them. And also during the discussion, Dr. Aruna brought out the point about the MTP, Massive Transfusion Protocol. Our own practice here now is actually to keep at least 4 units of blood and 4 units of plasma readily available when you are planning a case. And as was mentioned earlier, now often we are able to do even a percreta placenta without blood transfusion. That's a different matter. Still, you should be prepared, because you never know when the placenta has come out of the uterus. You never know when there will be a little extra bleeding. Even after you clamp the aorta, there can be more bleeding when it is a placenta percreta. So here again, what we are showing you is how we can take care of the extruded placenta from the Another case, again, bladder separation, how difficult it can be is shown here. Because in doing the placenta accreta spectrum, all the other things are not the difficult ones. Difficult one is this separation of the placenta. You can see that is a bladder all over, and separating it from the extruded placenta is the most difficult thing. As you can see here, separate it patiently so that you don't injure. And that is the bladder, which was adherent here. That's the placenta, which is extruded. For saving time, I'm just running it through. You can see now the whole bladder. You can see the whole bladder being lifted up, and still there is densely adherent area over there. You can see how densely adherent the placenta, the bladder can be on to an extruded placenta. Separate it carefully so that you will get it all below the level of the extruded placenta. Once you have gone below that level, then after that you can, it's always better to go by sharp dissection rather than just blunt dissection. So get that whole placenta out from there. So that's the whole bladder, and that is the extruded placenta over there in a percreta placenta. So these are a few cases of placenta accreta, which I thought I will share with you. And if there are any questions, then probably we can entertain that.
Yes.
With the permission of Siren sir, I express my gratitude and thanks to Piley sir, because that case, the first case demonstrated Kottayam, I was assisting it, and that day I got the strength to continue with doing the same procedure. So my thanks are due to sir. And one more, I would like to have your opinion regarding one thing. See, we know that this placenta accreta spectrum, the basic pathology is pre-existing damage to this endometrial myometrial interface. So at the time of primary cesarean section, earlier when we were postgraduate students, we were taught that we have to exclude the endometrium or the decidua and then suture the first layer of this myometrium and then the second layer of myometrium. But later, that point was that is not needed. That was the teaching. I think that that could be a contributory factor for this sort of a damage to that endometrial myometrial interface. So even now, I try to exclude the endometrium or the decidua, at least for the primary cesarean section. What is your opinion regarding that, sir?
There are conflicting views about the reasons why we have a higher incidence of placenta accreta of late. And one of the views is, as you said, the way the uterine wound is closed. And as you said, your view is that, is it because you include the decidua when you are doing the suturing that is causing the problem? That can be.
That is one contributory factor.
Yeah, one. But I think the most important reason is the level at which we are putting the incision now. Remember when we were students and later on early in our practice, cesarean was almost always after the woman had been in labor. When you find that she's not progressing, then you take. Already the lower segment is formed. And the incision you make in such a case is at a lower level when you imagine the uterus is involuted further. It is at the isthmus. Whereas now, many times it is an elective cesarean whereas the lower segment is not well formed. Your incision is at a relatively higher level. And when the uterus has involuted, gone back to menstruation and waiting for the next pregnancy, the area where the implantation can take place is over the scar possible. Whereas previously the scar would have been at a much lower level. Now it is a more likely accessible or exposed area for the implantation to happen. This, I think, is a more important reason why we are having more and more of accreta, percreta problems now. The point that you mentioned about the way to close the uterine wound, I think if this is the 2 layers and the far near far principle to bring the myometrium to myometrium is the important thing. Whether your bite goes through a little decidua is not the important thing. Important thing is to make sure the myometrium to myometrium approximation takes place like that. Now, the other point that some people raise now is the 2-layer closure. Is it because we have gone away from the 2-layer closure that isthmocele is more and whether placenta accreta is more? I do not know. Personally, I feel even 1 layer properly taken is probably the one that is the best thing to do. In fact, in Australia, New South Wales, you would have heard when Henry Murray was here in Kerala to explain to us, he was saying they did a randomized study on this. And they found that where they did the 2-layer closure, the chance of accreta is more than when they did the 1-layer closure. His argument was, when you do a 2-layer closure, you are making more ischemia of the suture area, and that is why. These are all hypotheses. I do not know. But the best thing to convey to our juniors is approximate any wound keeping this principle, myometrium to myometrium, decidua to decidua. And of course, some people say that I will put an incision in the lower part, no separation of the peritoneum or anything, just a stroke, baby is out like that. I think we have to be careful with such dramatization of procedures. You separate that peritoneum, keep it down, put your incision a little lower down so that that peritoneum will be there to cover that area. So at least this will help to reduce the adhesion of that uterus to the anterior abdominal wall, which is such a big problem now, as well as momentum and bowel even coming to form adhesion at that point. Having said that, there is the other side of the story also. People will argue that you are incising the peritoneum and keeping the bladder down with a doyens is the reason for percreta placenta, because your incision is over the bladder. And so are you not paving the way for invasion of the bladder when it has healed? So there are arguments one way or the other. There's one other question that was remaining in the discussion earlier, whether to use vasopressin in the lower segment. Yes, as I think Kunjama mentioned and many others mentioned, there is a concern in using vasopressin in the pregnant uterus. But it's not that dangerous. What we have found is that if you apply it, inject it with the dilute vasopressin, locally there is a lot of hemostasis achieved. So it is not a dangerous thing. Even though earlier I also was a critical of that, I would say that in patients who have very big vascularity over there, a little bit of vasopressin also may help. Thank you very much.
One question ask. One question, Dr. Jyoti.
Yes, Aruna. It's nice to see you.
Sir, good evening, sir. So I just wanted to ask you, there are some books which mention when you're dealing with a PAS, then you can do some of the steps even before doing the cesarean, like pushing down the bladder. And though I've never done it, but actually, what would be your views?
Actually, in Triple P, they are doing it. You know, as long as you haven't broken the contour of the uterus, as long as you haven't interfered with the blood supply to the placental area drastically, no harm. So actually, in those procedures, they are doing like that. They are separating the placenta and then only put the incision at the upper border so that they can access the baby without much difficulty with the placenta. Their upper border of the placenta, they will be there. So you can do that, yes.
So, and I mean, about pushing the bladder down much more than we would normally in a cesarean in these cases, so that that part of the dissection is over by the time we actually come to applying the clamps lower down.
No, I would not do that much because that is the most difficult part of the surgery. Getting the bladder down, lower and lower you go, more and more of a problem. I would limit myself to separating that superficial vessel is coming to the upper area of the bladder towards the placenta, get the baby delivered, and after that, only go for doing the complete dissection of the bladder down. Because otherwise it can be taking a lot of time and sometimes very difficult to control the bleeding. A very distended uterus like that, with the bladder also there, is stretched more, and there is more likelihood that you will injure the bladder than when
actually mentioned in Williams. So that is why I was a little, though I've never done it so far.
No, see, the problem is people who are doing these cases are for example, when you said it is the Williams, they are oncologists who do these things there. Oncosurgeons are the ones who do there in the US too much. Vascular surgeons are the ones who do more in the UK or that, not obstetricians. Many other places, they don't do that. And so they go the way they do for their oncology work. I know your interest is also oncology, but is it oncology that you're interested in? But many times they are the main members of the teams. And so I wouldn't recommend that.
Right. So, and how long do you keep the clamp, sir? When you keep the
clamp, see, we have kept in 2 patients, we have kept the clamp for nearly 2 hours.
Okay.
2 hours. See, the point to remember is below that level of the aorta, there is no vital organ involved. It's the lower limb. And lower limb, in these cases, we will put the compressions, not the stockings, but the pump, DVT pump also, when we are doing it, so that it will not allow that much of stasis. So that is the way we can do it actually. No harm. And post-operatively, of course, this patient should get thromboprophylaxis and ambulate at the earliest.
Yes.
And the catheter, if any injury to the bladder, of course, you have to keep the catheter long term.
Thank you, sir.
You're welcome.
It was a pleasure listening to you, sir.
Thank you,
so
Erna. Thank you. Okay.
Thank you.
Any other,
Thank you very much.
Jyoti, any other
Thank you very
question? I know I
much.
have.
Thank you. Just one question which was answered, sir. Thank you
Sorry?
so much. There's just one question which was answered, asked by Dr. Aruna, was that how many minutes do you clamp the aorta? By one of the faculty from AFMC only. That you have already answered. Thank you so much. I think it has cleared lots of doubts in.
Yeah, thank you.
Can I add one more thing? You have
Yeah,
to
please,
anticipate
go ahead,
hematuria also. Like,
Hematuria.
we had a case, 20 weeks presenting with hematuria, and she was in shock. And on examination, the bladder was distended above the level of umbilicus. So we had to do a cystotomy first, and then only we could do a hysterotomy and take out the baby with the help of urologist, of course. So that also we have to anticipate. Even at 20 weeks, it happened. So all the problems we have to anticipate in case of placenta or a greater spectrum.
That is not difficult to imagine what would have happened there, because the placenta would have been percreta, and then a percreta placenta onto the bladder would have invaded the bladder wall. But one thing I want to remind the audience is that even though Kunjamma mentions this case about the hematuria or the bladder bleeding into the bladder at the time, it is a very rare event. Very seldom, only you will see, practically never, you see coronary villi projecting into the bladder wall, into the bladder cavity. They are invading the bladder wall, and you see very vascular wall of the bladder, but still it is not into the lumen of the bladder. So what I am trying to say is, sometimes if it is so bad as Kunjamma mentioned, you may have to even take a part of that bladder wall over there and suture it well, but it is never that, it invades and causes the trophoblast or the coronary villi to go into the bladder cavity. As usually I say, to remember that is, coronary villi is looking for blood and not for urine. So they will not go into the lumen of the bladder. They will go only into the blood vessels.
Very good. Very good.
Thank you very much, sir.
Thank you, Jyoti.
Thank you
It's a
for
pleasure for this opportunity to be there with you.
Thank you.
Thank you. Thank
Now
you.
we are running behind schedule. We'll
Never
go
mind.
to the next session. I would like sir to introduce Lalitambika madam and Chella madam to introduce Ambujam madam. CV please. Lalitambika madam CV please. Venu. Dr. Lalitambika.
Ma'am, is this visible?
No, this is Dr. Ambujam visible. Lalitambika.
Who is introducing? Jyoti?
Shekhan, sir.
Okay, I didn't get it before. So. Okay, so even if the slide is not there, it's okay. Are they putting the slide?
Slide leda.
Are you keeping the slide? Otherwise, let me go ahead.
You can go ahead.
Okay. Welcome back, everyone. We are very happy to have Professor Lalitambika as one of the faculty here. She has just qualified to become the former professor. She was the professor recently at Arapian Medical College. Very active person in the federation. She was the former president of our federation also, having achieved many things as in the association as well as in the teaching side so far, and continue to teach the students. And I am sure that we are going to benefit by the deliberations today. The students will be benefited definitely, and all of us who are listening. So welcome, Professor Lalitambika, and thank you very much for accepting our invitation, and welcome you for the session. Thank you.
Chellamma Madam, please introduce Professor Ambujam. Next slide, please. Chellamma Madam. Chellamma Madam's connection. Happy to introduce Professor Ambujam, Professor and HOD, Government Medical College, Thrissur, Chairperson of Maternal Fetal Medicine Committee of KPOP, Past President KPOP, and Dean of Kerala University of Health Sciences. So I invite postgraduate Vidya from Thrissur, Government Medical College, Thrissur, for the case presentation. Chairperson. Please stop sharing. Vidya?
Hi, yes, madam.
You can start.
Good evening, everyone. Today I'm going to present a case of placental abruption. I'm presenting the case of Mrs. X, who is 37 years old. She studied up to 10th standard. She's a homemaker hailing from Chemmanur. She belongs to below poverty line socioeconomic status, and she is married for the past 13 years to Mr. Y. Her husband is Mr. Y, who is 43 years old. He studied up to 10th standard and he's a manual laborer. My patient's obstetric score is she's second gravida with history of previous one miscarriage. Her last date of menstrual period was on 23rd September 2020, and expected date of confinement is 30th June 2021, and the gestational age is 34 weeks and 5 days. Her blood group is O positive. Now coming to the history of presenting illness, the patient came with complaint of lower abdominal pain for the past 6 hours. The pain was continuous in nature and had progressively increased. She also complains of absent fetal movement since the past 3 hours. She went to local hospital. From there, she was told that her BP was high and fetal heart sound was not heard, and she was referred to our hospital. There was no history of bleeding per vagina, no history of vomiting, epigastric pain, blurring of vision, or breathlessness. The history of present history, she was booked with regular antenatal checkup from a taluk hospital nearby. First trimester, it was a spontaneous conception. Urine pregnancy test was done 2 weeks after missing periods. She took folic acid tablets. She was given progesterone injections once in a week. There was no history of spotting vagina, urinary tract infections, fever with rash or hyperemesis, no history of radiation exposure or other unprescribed drug intake. Dating scan was done at 77th week and the dates were corresponding. NT scan was done at 12 weeks and was to be normal. GT was not in the first trimester and there was total 3 antenatal visits in the first trimester. Second trimester, quickening was felt at the 5th month. 2 doses of injection TD were taken. She took iron and calcium tablets. She was started on
lost her connectivity.
Technical team, you are having the slides.
Yes, ma'am, we have. I'm sharing it. I'm sharing it.
Oh, she is back.
Yeah. Vidya, unmute.
You should unmute, Hridya.
Second trimester, yeah. Vidya, are you there?
So let the other PGs present, then looking at the slides, what to do.
Okay. Shamina, you can do that?
Yes, ma'am. Ma'am, I cannot see some screen. There is some problem. Okay, ma'am, second trimester. Quickening felt at 5th month. Injection TD, 2 doses were taken. Took iron and calcium tablets. She was started on tab aspirin, 75 milligram. At night from 5th month onwards, she had history of dyspnea on climbing stairs at 6th month of gestation. Cardiology consultation was done, echo done and found normal. She was reassured.
Now, Shamima, can I ask you, she's a second gravida, first abortion. She's 37 years. And along with NT scan, any other tests that you will do? And what is your comment regarding starting aspirin from 5th month onwards and the dose?
NT scan, along with the NT scan, as the maternal age is 37 years, we have to do double marker also. Then specifically, we have to look for uterine artery pulsatility index.
Yes.
If the uterine artery pulsatility index is very high, we have to start on aspirin. Recommended dose is 150 milligram HS.
Month onwards.
It is better to start after the cardiac activity is in
early, isn't it?
At the earliest, we have to start.
Okay, that's what I meant. Okay, carry on. Anyway, she had a cardiology consultation and nothing was okay, no problem.
Second trimester continuing. Anomaly scan was done at 20 weeks and said to be normal. 75 gram GTT done at 6th month and she was said to be normal. No history of gestational hypertension or thyroid disorders. No history of abdominal pain, leaking PV, bleeding PV. Total 3 antenatal visits in the second trimester. In third trimester, she was detected to have gestational hypertension at around 32 weeks of gestational age. That is 2 weeks prior to admission. During routine antenatal visit, she was started on an antihypertensive tablet, which she used to take twice daily. When she was detected to have hypertension, some blood investigations were done and were said to be normal. No urine investigations were done. However, no further blood pressure checkups were done for the 2 weeks in between.
Okay, so when you detect hypertension at 32 weeks, she was started on an antihypertensive drug. And what is your comment regarding the management? What do you do at that point of time? You have started antihypertensive drugs. What all investigations will you do? And when will you ask her to come back?
We have to look for the PE profile for the patient. When we see the a high BP recording, PE profile include the complete blood count with platelet counts, then LFT, RFT, then RBS of the patient.
Okay, everything was done and
Yes.
it was normal. Okay,
That's
okay.
it to be normal.
Sure. Okay. Okay, carry on.
Third trimester continued. No history of GDM. Continued on iron and calcium supplementation. Continued tab aspirin at night till the day prior to admission. She was appreciating good fetal movements and there was no history of bleeding or leaking per vagina or pain abdomen till the day prior to admission. Now she came with the presenting complaint. Her menstrual history, menarche was at 12 years and she had regular cycles of 5 days of bleeding of 28-day cycle. No history of dysmenorrhea or menorrhagia. Previous 3 cycles were regular. Her LMP was on 23rd September 2020. Marital history. She was married to Mr. Y 13 years back. Her husband was a non-smoker, non-alcoholic. Husband's occupation, he was a manual laborer. Non-consanguineous marriage. Started treatment for infertility 2 years after marriage. History of ovulation induction multiple times and IUI done twice. Then past obstetric history. First pregnancy, it was a spontaneous conception 4 years after marriage. Detected by urine pregnancy test done 2 weeks after missing her periods. History of spotting per vagina at 2.5 months of gestation. Ultrasound was done and it was suggestive of absent fetal cardiac activity. Dilatation and evacuation was done. Post-abortal period was uneventful. Resumed menses 1.5 months after abortion. Then past medical and surgical history. No history of hypertension, diabetes mellitus, asthma, tuberculosis, kidney disease, cardiac disease, connective tissue disorders, thyroid disease or epilepsy. No history of previous surgeries. No history of blood transfusions or any drug allergy. Then family history. No history of hypertension, diabetes, heart diseases, connective tissue disorders, epilepsy, thyroid disorders, chronic kidney disease, chronic liver disease, psychiatric illness, or any other hereditary illnesses in the family. No history of intrauterine fetal demise, stillbirth, or recurrent abortions or congenital anomalies or twinning in the family. Then personal history. She enjoys a non-vegetarian diet, normal bowel and bladder habits, sleep and appetite was normal, no habit of smoking, alcohol intake or other addictions. Then diet history, non-vegetarian diet, her daily calorie requirement is 2250 kilocalorie per day and her intake is 2400, which is adequate. Her daily protein requirement is 60 gram and her intake is 60 gram, which is adequate. In socioeconomic status, she was studied up to 10th standard. She is a homemaker. Total family members are 4 and belongs to BPL family. And on general examination, she was moderately built and nourished. Her height was 156 centimeter. Pre-pregnancy weight was 50 kg. Then BMI is 20.55 and her present weight is 60 kg. No pallor, cyanosis, clubbing, icterus, pedal edema, or lymphadenopathy. Her vitals, pulse rate is 80 per minute, BP 150.
Yes, carry on.
BP 150 per 100 mm of mercury in the right arm, sit in the sitting position. Her respiratory rate is 20 per minute and she is afebrile. Hello. Her breast and thyroid was normal and spine and gait normal. On systemic examination, cardiovascular system S1 and S2 heard, there were no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds. Central nervous system, there was no focal neurological deficits. And on obstetric examination on inspection, Abdomen was longitudinally distended. Linea nigra and stria gravidarum was present. Umbilicus flushed with the skin. No scars, sinuses, dilated veins, hernial orifices free. All quadrants move equally with the respiration. On palpation, fundal height corresponds to 36 weeks, more than the period of gestation. Abdomen was tense and tender. Symphysis fundal height was 35.3 centimeters. Abdominal girth was 100 centimeter. And fetal parts were not easily palpable as the patient was not allowing palpation because of tenderness. However, the fetal head was palpable in the lower pole. On auscultation, fetal heart sounds were absent. On local examination, vulva was normal, vagina normal. On perspecum examination, cervical os was closed. On pervaginal examination, cervix was firm, posterior, uneffaced, os closed. Presenting part was above the brim. Pelvis was adequate. Modified Bishop score is 0. In summary, 37-year-old second gravid with one abortion, married to Mr. X, 13 years, with history of treatment for infertility, now conceived spontaneously, with excellent dates at 34 weeks and 5 days of gestation, with history of recently detected gestational hypertension, presented with absent fetal movements and pain abdomen. On examination, reveals a BP of 150/100, tense and tender abdomen with uterus corresponding to 36 weeks of gestation, singleton fetus in cephalic presentation, and absent fetal heart sounds with an unfavorable cervix. And diagnosis, 37-year-old second gravid with A1 with severe preeclampsia, singleton fetus with features suggestive of abruption and intrauterine fetal demise, grade 3A abruption, Sher and Shetland's classification, with no features of coagulopathy.
So what do you think might have predisposed to the abruption, and was it preventable? Shamima.
Her BP was high. So we had 2 weeks prior, she had a history of high BP recording and started on antihypertensive. She have to come back for BP checkup.
Would you admit her when you find high BP recording for the first time? Would you like to admit her and evaluate, or keep it as an OP and manage?
If the BP recording is not very high, we can manage her on OP basis after doing the basic investigations, and when it is normal.
What was the first recorded BP?
That we don't know actually, isn't it?
Yes, ma'am.
She just said.
What would you do? Such a patient, elderly patient, long period of infertility.
This is a very high risk case. So what
yeah,
would you
like to
ideal
admit?
Management?
What should be the ideal management?
Ideally, we have to admit and work up as her gestational, the maternal age is very high, and the main risk for abortion is, one of the risk factor for abruption is advanced maternal age. So we have to anticipate this risk factors and admit the patient in ward, and look for the, we have to give the antihypertensive, and we have to look for BP
at least
charting.
48 hours you admit, you evaluate, not only abruption, you have to think of other complications of hypertension, rule out complications. Only if she is stable, you will discharge. Such a high-risk patient, preferably you would like to continue her in the hospital, isn't it?
Okay.
Was the albumin positive? Why did you say preeclampsia, urine albumin was positive? Or any end organ, evidence of any other end organ damage? BP was 150/100 only. It doesn't come in. Fetal demise, you cannot say it is preeclampsia. It is due to abruption. Is it preeclampsia or gestational hypertension? For perfection's sake, in the exam, you should differentiate. Is it gestational hypertension or preeclampsia?
Madam is telling us because we are not sure about proteinuria. You
There are
cannot
other
say
end organ
preeclampsia in the diagnosis.
Yes.
Okay.
So you can say gestational hypertension.
Yes.
So
So
when
the
it's such
patient
a
has come, yes, such a patient has come now with lower abdominal pain, no visible bleeding, fetal heart sound absent, What are you going to do? What will be your management? She has now just landed up in the labor room. You are seeing her and you have diagnosed it. What are you going to do now?
We have to confirm the whether the fetal demise has occurred or not. We have to check for the BP and first stabilize the patient. Then
first you will do the ultrasound, or you will see, as you said, the vitals are stable, isn't it?
The vitals are stable. We have to confirm the fetal status by ultrasound.
Okay.
That is whether the FHS is present or not.
Where will you do the ultrasound for this patient? Will you send her to the
It is
radiologist?
available in labor room.
Bedside ultrasound only.
Yeah, bedside only.
Should be only a bedside ultrasound. You cannot send this patient out.
Okay.
Isn't it?
Another
So
comment
what
I
all
wanted
things
to
you will
make
do
is
immediately?
actually, you did the vaginal examination. Or you have to do a vaginal examination only after confirming that the placenta in the
is in
previous
the upper
scan was at the upper segment.
Okay. Okay.
Okay, fine. Carry on, Lalitambika.
So what all things you will do simultaneously? Here probably it's a case of what type of abruption? There is no extra.
It may be the concealed abruption.
It is
So we
associated
cannot
with more
anticipate the
complications.
amount of bleeding. The clinical features will not be correlating with the amount of the bleeding. So we have to anticipate the patient going into DIC.
See, how will you manage what Dr. Ambujam has asked the question? What
Yes,
are the
you said
things you
only
are
about
going
the ultrasound.
simultaneously?
So what will you do
You cannot
simultaneously?
wait for the scan
She is
report.
bleeding inside.
Yeah, she is bleeding. So what all things you will do immediately?
Call for help. We have to call for help. That is, we have to have a multidisciplinary team to manage an abruption.
Now she is stable. What all things you will do? Even as a resident inside, you will inform your senior, but what all things you will do in the labor room immediately?
We have to arrange for blood. We have to do the basic investigations. Then IV cannula, 2 wide board IV cannula is put.
Take a blood sample, send it.
Blood sample.
Yeah. You have
What
to
all
inform the blood
investigations
bank.
will you do?
Inform the blood bank that such a patient is there, you may require more blood and components, isn't it? Then what else you will do?
Then we have to do the basic we have to send a PE profile at the time of admission while taking the while putting
What
the
all
can.
investigations you would like to do immediately for this patient with suspected
Complete blood
concealed
count,
abrasion?
arrange blood by cross matching, then RFT, LFT, and RBS is sent. Then urine alcohol.
Any important test that you will immediately do. You are taking enough blood.
BTCT.
Not BTCT. What other important tests?
PTIN. APTT is done.
You have to send for APTT, PTIN. But what test you will do? Bedside test, which is very useful for you to come to a conclusion whether she is having DIC or not. Bedside test.
Clot retraction.
You have to do a clotting time and a clot
Clotting time.
observation.
She said BTCT. We will do the clotting time. Okay.
Clotting time and clot observation test. How will you interpret that test? How will you interpret because it will take some time for APTT, PTIN, all these results to come. You also will have to send serum fibrinogen because it will give you a lot of information regarding the coagulation status and prognosis. How initial fibrinogen level will give you the prognosis?
If the fibrinogen level is less than 250, there is chance for patient going into DIC.
If initial value is more than 300, very unlikely that she will go for coagulopathy. So that also you'll have to wait for some time for the result. Immediately, how will you interpret the clot observation?
Clotting
can look for clotting time.
Blood in a red cap tube, dry tube. Observe how many minutes it takes for the clot to form. Then what do you do? That is the next important thing. After observing the clotting time, what do you do? Keep it undisturbed, and at the end of 15-20 minutes, you see whether the clot is remaining retracted or it has undergone lysis. What does it indicate?
If lysis has occurred, clot is not stable, that indicates the patient. The patient has gone into coagulopathy. That is conception of the coagulation factors.
Fibrin degradation is going on. Fibrinolytic system is activated. That is the conclusion. That means patient is in DIC. So
Yes.
every place you can do the simple test. Simple is not a validated test, but we have been doing it since several years and it's found useful. Meanwhile, you will get investigation results and you can depend more on the investigations.
Now, Shamima, if you were working in a highly equipped facility, what else can you do other than the clotting time immediately with the blood?
To find out the coagulation status.
To find out the coagulation status. Any other tests that you can do?
You don't have to wait.
Immediately you can get all the results. Yeah.
PTNR and hepatitis.
No, that will take some time. Any other test?
Immediately you add blood to the system, it will tell you immediately.
What is that?
All the components of coagulation except one.
Thromboelastogram.
Yes,
thromboelastogram.
Yes, it is very important nowadays, and of course we are not used to it because it's not
I think
freely
in Thrissur,
available.
Jubilee, it is the thromboelastogram.
Yes, but you should be knowing it. Okay,
No.
so that has actually changed our way of management of coagulopathy. You can give whatever product is deficient, and you
will
get the
tell you.
results very fast.
And what component is not told by thromboelastogram? Which component you will not get an idea about?
Platelet.
Platelet you will not know from this thromboelastogram. Okay, immediately.
Okay, fine.
You are going to give for this patient is you put IV line, arrange blood, alert blood bank, they do the clot observation test. Then you have sent all the investigation for renal parameters. What else you will do now immediately? What else you want to know?
And Shamima, you said you will do the ultrasound to look at the fetal heart. That's all? What is the role of ultrasound in this patient? You just explain.
Depending upon the status of the fetal heart, we have to decide upon the termination.
No, it is already IUD. Madam is asking what are the
What is the place of ultrasound?
You are suspecting a concealed abruption.
What are you looking for?
Ultrasound be able to tell you something else.
If it is a concealed abruption, or we have to diagnose whether it is a abruption or any other cause that is concealed abruption.
The question is very straightforward. Will ultrasound give you any other information than fetal status? Whether fetus is live or not?
Placenta previa.
You can unsuspected, maybe placenta previa, but here the picture is that of typical abruption. You have to localize placenta. What else? Look for retroplacental clots, isn't it? Also, fluid blood tracking between the membranes and the uterine wall. It has not yet come out, but there may be collections of chorionic collection between the chorion and the uterine wall. These two are important. And what is the place, how much you can depend on ultrasound to diagnose abruption?
Yes, what is the sensitivity?
Sensitivity and specificity.
There is not much role for ultrasound in
You
diagnosis.
can say not much role.
You cannot say like that.
25 to 50% chance.
See, if you see a retroplacental clot, well and good. But if you don't see a retroplacental clot, you can't say this is not abruption. Because sometimes you will see only a thick placenta. Because the echo pattern of the clot will be same as that of placenta. So you may find the placenta is thick. You may not identify it as a clot. So when you see a thick placenta also, you suspect abruption. But in this case, actually, all these are not important. Clinically, it is very evident that it is abruption. So what will you do next?
What is your plan of management?
So along with IV line monitoring investigation, one more thing you have to do, which is the organ that may be grossly damaged by abruption.
Kidney, we have to do a catheterization.
That's very important. You have to
yes,
monitor urine output. You have to put in an indwelling catheter. Then, what next?
We can do
PV. We can assess
PV you have done, it is a quite unfavorable cervix. But patient is complaining of continuous pain. We are not sure whether there is uterine contractions or not. What determines the prognosis in abruption? What is the most important factor?
Amount of bleeding.
This is a concealed abruption, isn't it? Concealed
Abruption,
one.
delivery interval. The interval between onset of abruption to delivery. What should be the ideal time before you should deliver?
20 minutes.
Huh?
20 minutes.
20.
4 hours. If the patient is stable and she had not
If
entered
this
into
patient, your
coagulopathy.
patient, IUD, baby is already dead and she has concealed hemorrhage, what time you can give? Suppose the cervix was favorable, what would you do? Maybe it was.
Induce.
You can do an
what type of induction? Be specific.
Don't say induce.
Rupture of membranes. And
you have to accelerate labor. You have to do artificial rupture of membranes.
Rupture of the membrane, then you have to start oxytocin. And what time you can give? What is should be the ideal abruption delivery interval beyond which patient will go for complication?
4 hours.
It is
What will happen if the placenta is separated and
retained inside?
Retained inside, the patient is not delivering.
Thromboplastin will be
the
related to the blood circulation, and she will go into disseminated intravascular coagulation.
Okay, so you want to deliver as early as possible.
Now, what do you think about the severity of abruption? It's an IUD. So, what do you think the abruption severity is? It
grade 3.
Grade 3 abruption.
And the cervix is arnifaced and os is closed, isn't it?
Grade.
So, what is the ideal management in this patient?
Os is closed. She's only 34 weeks. So very unfavorable.
Cesarean section. You have to plan cesarean
So do you
section.
expect a vaginal delivery on induction in this patient?
No, ma'am.
You do not expect. So what will you do?
We plan for a CS emergency cesarean section and prepare the patient as such and take for the CS and deliver out the baby and the.
Okay, now regarding the cesarean section, this is a severe abruption and concealed type. What are the problems that you expect? So what will be the incision and all that? You cannot just do a cesarean just like that. And another thing is how to plan about the anesthesia. What will be the ideal anesthesia? Tell us something about that.
Regional anesthesia is now.
This is a patient with severe abruption who can go for a coagulopathy on the table. So
even
what
anytime
incision?
she can go into shock. Already the amount of blood loss is not known to us. Much blood has collected inside. Anytime she can go into shock. It is very unlikely that her pulse was very normal at the time of admission. This concealed bleed. At least there will be tachycardia even if there is no BP fault, isn't it? Okay. Answer madam's question.
Yes.
General anesthesia is preferred.
Yeah, whenever a patient is suspected or going to be on the verge of coagulopathy, better avoid regional, isn't it? So, and what about the incision?
Vertical incision.
Vertical incision is preferred, isn't it? Okay,
Why?
then.
Why?
What is the reason?
What is the reason?
Because she may develop atonic PPH or PPH due to
that we can manage through a
coagulopathy.
transverse incision, no problem. Why do you want a vertical incision in a patient who may have DIC?
Easy access.
No. What complication you are trying to prevent?
Hematomas can form.
Internal death have occurred because of a particular complication of cesarean.
Hematoma.
Hematoma in which part?
Rectus.
Rectus sheath hematoma. So when DIC is there, there could be bleeding, and later on patient can again go into shock and we may require a relapse. So such patients you always prefer a vertical incision. So bleeding will be minimum and complication will be less. Then what else? You have put a vertical, delivered the baby. What all things can happen?
If there is a concealed hemorrhage, there is chance for atonicity.
You can go for severe
postpartum hemorrhage.
Postpartum hemorrhage. What can be the appearance of the uterus?
Cuvular uterus.
Cuvular uterus may be the
Especially in concealed, isn't it? Because
Concealed,
there is
right.
no way for the blood to escape.
So how
Okay,
will
so when you
manage?
find a covariate uterus, how will you manage?
We have to anticipate postpartum hemorrhage in cavalier uterus because the blood has seeped into the between the myocytes. So the contractile function of the uterus will be lost. So compression sutures are better put at the placental bed to reduce the bleeding, because sometimes sinuses will be open in abruption, so it will continues to bleed. So compression sutures and small square sutures will be put at the placental bed to prevent PPH.
What about medical management? It is atonicity, isn't it? So immediately you have to give prophylactic
Active
medication.
management.
If she is bleeding,
Third stage.
You are expecting atonic PPH, so you have to give the uterotonic agents, isn't it? Even though at cesarean section, you have to give all those oxytocin.
now even in coeliac uterus, sometimes you don't find atonicity.
Yes,
Can you
practically
explain that?
speaking, all these uteruses
Yes.
will contract.
Can you explain that?
Because of the blood seeping into the myometrium, there will be tetanic contraction of the myometrium.
It is not only by the blood. It is said that there is
Thrombin releasing.
thrombin.
Thrombin released.
Yeah, thrombin is a strong uterotonic
Thrombin
agent.
is
Plenty
also
of
a
thrombin
uterotonic agent.
generation is there. So that thrombin may be responsible for making the uterus contract and prevent bleeding. That is one reason. So if she is bleeding, first you will go for definitely medical management. Then parallel, you will have to go for compression sutures. And is it an indication for hysterectomy, coeliac uterus with atonicity?
No.
It's not an indication. You can try medical and surgical management and preserve uterus. Now, what are the other complications this patient can have? You have delivered, managed PPH.
And go into DIC.
DIC,
DIC.
renal failure,
How will you
shock.
manage DIC?
We have to supplement the blood products like
Fresh frozen plasma,
cryoprecipitate.
So how much, what is the indication for cryoprecipitate?
If the fibrinogen level is less than 150 milligram,
then
we have to
100.
supplement.
How will you calculate the dose of cryoprecipitate? How much you will give?
1 unit per 5 kilogram.
10 kg. 1 unit per 10 kg.
10 kg.
That is the usual calculation. Then what about platelets?
Platelets, 1 unit per 10 kg itself.
Yes, it's again 1 unit per 10 kg. Minimum you will have to give 5. And
Five.
what type of platelet is preferred?
Ferritic platelet.
What is the advantage?
The platelet count will increase in a larger amount, and it is from a single donor, so no chance of
So exposure to multiple donors can be prevented.
avoided.
Other complications? One is DIC, then
Renal failure can occur.
due to
Acute kidney injury.
Acute cortical necrosis.
yes, or
Then
acute cortical necrosis, or what else? Which is more common?
shock because of the hypovolemic shock.
So what type of renal injury is more common? And which has got a
Kidney
better prognosis?
Acute kidney.
Acute kidney injury.
Acute kidney injury,
Pre-renal.
to cortical necrosis, maybe pre-renal, pre-renal shock, renal cortical necrosis, or what else? Which has got a better prognosis. Cortical necrosis prognosis is very bad. Patient will be dependent on dialysis. What is it? Acute tubular necrosis. So tubular necrosis will improve with time, but cortical necrosis will not improve. Then any other complications? So DIC,
Can go in for shock.
kidney injury.
Okay,
So
what are the
DIC
problems for the, you said about the maternal complications. What about the problems for the baby? Now, leave alone this patient. What are the problems when a patient develops abruption? What happens to the baby? What are the risks for the baby?
Prematurity can be there if it is
Prematurity, yes.
neurological neurodevelopmental injury can occur to the baby. Then there are chances of stillbirth and neonatal death can occur in the near future.
Hypoxic yeah, hypoxic encephalomalacia can be seen. Sudden infant death syndrome, neurodevelopmental delay. All these are problems for the baby, isn't it? Okay,
Yes,
now you just tell what are the, so whenever, that is why maybe Hridya might have told about the 20 minutes to deliver the baby if the baby is alive, isn't it?
Now,
If
what
the
are the
baby is
indications
alive,
for
fetal heart is present, you have to
cesarean?
rush and do a cesarean section as early as possible. Okay, carry on, Lalitambika.
What are the indications for cesarean in abruptio placenta?
If the fetus is alive and and vaginal delivery is not imminent, or if we have induced the labor and there is no progress of labor, or if there is severe bleeding and vaginal delivery is not imminent.
Anything else?
Placenta previa.
Not previa, we are talking about abruption. See, you are monitoring the urine output. Though the labor is progressing, if she is going into renal shutdown, you cannot wait further. That may be an indication for immediate termination. Again, once you have a DIC and you correct the DIC, still undelivered, you will have to do cesarean. You cannot wait further once the DIC is correct. Now coming to DIC, even if you correct DIC, sometimes the mother dies. Why? In spite of correction of DIC, maternal death can occur. What is the reason?
Renal.
See, what is the pathogenesis of DIC? What happens?
Consumptive coagulation.
Consumptive coagulation. So initial phase, what happens? Coagulation of blood in microvasculature of all the vital organs. So that is the initial phase. Coagulation of blood in microvasculature of vital organs leading to organ infarct. Severe ischemic damage of all major organ systems. So in spite of your correction, finally you may lose the patient because of multi-organ failure. That is the one thing you have to remember. So the thromboelastogram may help you in identifying the phase of DIC and managing appropriately so that you can reduce this multi-organ damage.
Another point is when a patient we are attempting vaginal delivery and DIC sets in, you cannot wait till the whole of DIC is corrected. You have to immediately start all the components and urge to deliver the baby also, because as you prolong the delivery of the fetus, this DIC will be continuing. So we need to hasten the delivery of the baby. So it should be simultaneous. Correction of coagulopathy as well as evacuating the uterus.
I had initially some connection problems. So coming back to your first trimester, can you predict abruption?
By measuring the double mark.
So you were talking about double marker.
We can predict preeclampsia. Early onset preeclampsia can be predicted by the history, then biophysical markers and biochemical markers.
Yes, preeclampsia can be predicted. Now there are reports which say that if your HCG level is high, if your inhibin level is less than 5th centile or more than 95th centile,
low PAPE
high, all these are associated with higher incidence of abruption. So at the first trimester screening itself, you can not only look for the risk of trisomy, but you look at all these biomarkers and have a note whether this patient is at risk of abruption. You can have an idea. You can predict.
What is the association between folic acid and abruptio placenta? Is there any evidence?
Folic acid deficiency can cause hyperhomocystinemia, which which can cause hypercoagulable state and can predispose to abruption.
Okay, so it is through the hyperhomocystinemia. Otherwise, actually, there is no evidence. But still, we all give folic acid starting from the first trimester, isn't it? And in hypertension, also starting the antihypertensive drugs cannot prevent abruptio placenta. Okay, so it is unpredictable and happens all of a sudden. But in this patient, definitely she would have been admitted and hypertension managed in a better way.
What are the other risk factors other than hypertension?
Maternal age was 37 years.
Yes.
Then what else?
Increasing clarity, over distended uterus, polyhydramnios,
Sudden emptying of the uterus, even delivery of the first twin in a multiple pregnancy, isn't it? Then PROM is an important risk factor, PROM, that you have to be very careful. More the interval between rupture of membrane and delivery, especially in PPROM, while we are waiting, conservative management, suddenly abruption can occur and we can lose the baby. That's an important point you have to remember. If the patient has bleeding along with leaking, you should think of the possibility of abruption.
Submucous fibroids,
yes, placenta or implanting over a fibroid, septum, uterine anomaly, septate uterus, short cord, all these are associated. Single umbilical artery, yes.
Hypothyroidism.
Yes, maternal hypothyroidism, and also bronchial asthma is also supposed to be a predisposing risk factor.
What is chronic abruption?
Abruption which had occurred earlier can lead to oligohydramnios.
What is the difference in sudden abruption and chronic abruption? What is the main difference?
Chronic abruption, we can go for conservative management.
Now, what is the mechanism difference in the pathophysiology? What happens in chronic abruption?
Small focal abruptions will be there in chronic.
What is it?
Focal areas of disruption will be there.
Usually in the margin, it is marginal separation. So whatever blood is, placenta is separating, blood will be coming out, small bouts of bleeding, recurrent bouts of bleeding. That part of placenta will become infarcted. So that's why gradually the placental function deteriorates. So patient can go for growth restriction, oligoamnios and other complications.
Is there any role for conservative management in abruption? Shamima?
If it is only chronic abruption, we can look for. Otherwise, there is no conservative management.
No, very exceptional situation. Very exceptional situation. Abruption means always termination of pregnancy, but in very exceptional situation, just for the sake of the baby, if it is very mild and the mother is a small hematoma maybe, and if the baby and the mother are stable, patient in the hospital, only for the sake of the baby, in very exceptional situation, there is no role actually. Okay, is the time over, Jyoti?
Yes, ma'am. Thank you for the
very much covering the topic actually. Actually, nowadays the abruption is the incidence has come down because of the multiplicity has come down. So that's why students are on the practical side, they are not much experienced, probably not seeing the cases enough. So what the important thing, the practical thing the madams who are asking, immediately the patient has come, you have found that the uterus is tense and tender, absent effort, and the predisposing factors like the elderly patient and the hypertension. So you are sure about almost 99.99% you are sure that's abruption. Immediately put in a line, take the blood and send for immediately that bedside test. That is what they were repeatedly asking. Keep a dry test tube, do the clot observation test, how much time it will take. It may take 5-10 minutes in the tube test. After it has become clot, you cannot throw it away. Stick it on near the patient on the wall. That is what we are doing at Calicut. We were having so many cases at that time. And see the clot whether it is going to remain stable. or it may get lysed. So there is initially utilization of the clotting factors to form a big retroplacental clot. Then liberation of the thromboplastin because of the disturbance of the placenta and the membranes, liberating these substance in the system. So there is widespread intravascular coagulation going on, which will lead on to conceptual coagulopathy. And
so you got muted, sir.
I mean, the clotting and lysing going on, like that you will have coagulation. That's why the time interval of delivering the patient, and if the baby is alive, as I think Dr. Hidaya or somebody was telling, correctly use the word. If there is no sign of an imminent vaginal delivery, go for cesarean if the baby is alive. Otherwise, try to induce and deliver the baby. The time interval, again, they were asked repeatedly, 4 to 6 hours. Why these 4 to 6 hours? Within that time, coagulation failure, renal failure, shock, everything. So it is all crucial in the clinical management. Very well brought out the clinical points by both the examiners. This is how the question will be asked. Very well covered, Dr. Galdambik and Dr. Ambujam, because probably they were also doing the same thing in the initial phase when these cases were very much there at that time. And you may do occasionally hysterectomy also. The termination of the appropriate time without allowing development of this coagulation failure, renal failure, and shock. Okay, very well covered. Thank you.
Thank you, sir. Challama madam, you want to add anything? Just one
No,
word.
nothing to add. The discussion was very good. All the clinical aspects were covered. And one point to add is only there is concealed hemorrhage when there is no bleeding. You should be very, very careful. Don't delay the management. And the students also answered very well. And as sir said, when in the beginning of our PG days, there were lot of ampules on the walls of the labor room. In early days, the labor room was not like this at IMCH. Small rooms. Kunyamma may be remembering small walls in the labor room. All the walls, there may be a lot of ampules. We are checking for at that time. Ablation was very, very common. So that took us to guide about the management of ablation placenta. The students also answered very well. All covered the practical points. Thank you, Kunyamma and Ambika. Sorry, Ambika and Ambika.
I wanted to tell to any patient presenting with a preterm labor, you should always keep in mind it could be a case of abruption. Preterm pain, you should not ignore that preterm pain. You should always monitor the patient, rule out abruption, then only send the patient back to ward. You should observe the patient for some time.
Thank you, Lita. Thank you, Ambuja madam, for those lovely.
Jodi,
Thank you for the wonderful opportunity.
One more thing, I have to put a question, that is the risk of recurrence.
Yes,
so,
yes.
It's very, very important.
Yes. This patient particularly, yes. There is a chance for, there is a high risk. After one
tenfold increase in the risk of abruption. So in the next pregnancy, you should be very, very careful.
Most important factor predicting is previous abruption. In patient who had abruption earlier, there is a very high risk of abruption.
Thank you very much. Very good. We are running behind schedule. I request our introduce our next speaker, Dr. Sridevi Kohli. CV, please. Dr. Sridevi. She's going to talk on ultrasound in APH. Subhash.
Yeah, ma'am. Thank you very much, ma'am. I have the proud privilege of welcoming Dr. KV Sridevi, madam, a good friend of mine. I think we met just a couple of months back at Vizag at the South Zone UFOXY. Madam is a very dynamic person and is a very active sonologist. She has been a very active trainer in Hyderabad, in Chennai, and also has started her own center now at Vizag. She and the current chairperson, Dr. Chinmay Ratha, they have been doing a lot of training courses for postgraduates and for the consultants all over the Andhra and all over India. And I have the proud privilege of welcoming Dr. KV Sridevi, who is a fellow in Mediscan from Chennai. She's also done her advanced course from UK, and she's also done from Italy. So, madam, I have the proud privilege of welcoming you, and please give your address, ma'am. Dr. Sridevi.
Very good evening and thank you for the introduction. I should thank Dr. Jyoti for the invitation. And can you see my presentation?
No, not yet.
Can
Yes,
you see now?
Yes, ma'am.
Now it is visible.
And it's after a long time I'm seeing Dr. Shekharan sir, because as a postgraduates, we always used to run for his lectures when the CME sir used to come. So it's very nice after a long time being a part of the obstetrics thing. I just want to make it very quick and very crisp. One thing I want to tell the postgraduates is only if your mind knows, your eyes can see. That especially for the ultrasound, because we read ultrasound, but we see less of ultrasound. So I saw in the previous case discussions, the PGs were telling like, what are the things you see in ultrasound? Yes, 1, 2, 3. So let us see in my presentation how much they'll be able to recognize when the real picture comes on the screen. So I don't want to go for the definitions and all the things, but when it comes to the causes of placenta previa, most commonly it is placenta. The whole thing revolves around the placenta. Either it can be because of the where it has got implanted, or when it has got separated, or abnormal formation, etc. So unless we know what is normal, it is very difficult to say what it is not. So we can see this is a normal placenta having the basal plate, placental substance, and the chorionic surface. So the normal placenta here, because this wall of the myometrium is close to the probe, so this is anterior placenta, and this is the posterior placenta. So this is one clip. I just want the either Aparna or Hridaya to comment on what they see in this placenta. Dr. Aparna or Dr. Hridaya, can one of you comment what exactly you saw in the video clip? Can they hear?
Yes, madam.
Yes. So what is this? That's the bladder. Because this is the amniotic cavity and this is the fetus, this is the bladder, this is the myometrium, right? So the anterior one will be the bladder, right?
Yes.
And you can see the cervix and the placenta lower edge is very much above the lower uterine segment, yes? And what is this part of the uterus called? Where the U shape comes is the fundus of the uterus. So the upper portion of this placenta is near the fundus. So this placenta is anterior upper segment. And what are these things? Come on, just now I showed you the normal anatomy. Retroplacental network of vessels, that hypoechoic zone we are talking about, right? Which is lost in placenta accreta things. So this is what this hypoechoic area, what we see. And this is the placental surface, and this is the fetal side or the chorionic surface. Okay. So Shamim, can you tell me what we are seeing? Which side the placenta is implanted? This is the myometrium, which is close to my probe. So this is?
Posterior placenta.
Yes, this is posterior placenta. And what else we are seeing here?
Low lying.
Yeah, where did you say it is low-lying placenta? Oh, I'm sorry.
Below the presenting part.
Do we take the below the presenting part as the low-lying placenta?
No, it is reaching near to the os.
Yes. So what we can see here, this is the cervix. But can you see the anterior wall of the uterus here and the posterior wall of the uterus? Are they of the same width? No, right? So is this more?
Yes. Anterior is more.
Yeah, anterior is more and posterior is less. So usually the uterine walls are symmetric. So this isn't focal myometrial contraction. And you can even see, because I'm giving some amount of probe pressure, the cervix is ending here. Because when you give lot of probe pressure and when the women are very thin and there is anterior myometrial contraction, you falsely see an elongated cervix and you falsely think the cervix is here and the placenta is low lying. So this is one of the pitfalls where we might see the anterior myometrial contraction and think this is the cervix. So unless you see the internal loss clearly, you should never say whether it's a low lying placenta or not. So what scan is this? Is this a vaginal or abdominal scan?
Vaginal.
Yes. How can you say it's a vaginal scan? My probe is touching the cervix. Yes, the probe is touching the cervix. So this is a transvaginal scan. So what are the landmarks for identifying the things? Because I want to tell you the practical aspects. So this V-shaped bit is the external os, and this is the cervical canal, and this is the internal os. So many of us have a myth of saying that we should not do a vaginal scan when it comes to the placenta previa, right?
Transvaginal ultrasound can be done.
Yes. So transvaginal scan can be done, but you should not touch the cervix. You should be as gentle as possible. So how do you know that you have not given pressure? So can you see my probe here? The probe is in the anterior fornix. And can you see the width of the anterior cervix and the posterior cervix? So both should be of the same diameter. If you're giving pressure, your anterior cervical lip becomes thin and you can see indentation with your probe on that. So you should not do that, especially when you're dealing with the placenta previa. You should be very careful that you should try to avoid not touching the cervix, because sometimes when they have spotting or bleeding, you might provoke it, right? So in this case, this is the same patient which we saw abdominal. So where is the placental royer edge? It's somewhere far away, right? Right? It's here where you can see. So is it low lying or not? Not low lying. By subject to evaluation itself, you know it's not low lying. So anything you have any suspicion by abdominal scan, you have to always do a vaginal scan and confirm that this placenta is low lying or not. Okay. So transvaginal approach, yes, we have to do a transvaginal scan. This same thing, you have to put the transducer in the anterior fornix. The bladder should be empty. And you have your orientation should always have the internal os and the lower edge of the placenta in your picture. Then only you have to take the measurements. So what is this picture? What is this? What is this line? When you see this line on ultrasound, what do we call that? Membrane. Yes or not? So what is this lambda sign which we see in multiple pregnancies? Yes or not? So when we see this kind of picture, we know this is a dichorionic diamnionic because of the lambda sign. Why I'm showing you this is because the placenta previa or the abruptions is very common in multiple pregnancy. And here, is this T shape or lambda sign? Membrane insertion. So this is a monochorionic Is this monochorionic or dichorionic?
Chorionic diamniotic.
See, the two placentas very clearly seen, one on the anterior wall, the other on the posterior wall. So it cannot be monochorionic. So you will always see a lambda sign when both the placentas are implanted on the same side next to each other. But when you see two placentas on both sides, that means it is a dichorionic pregnancy. And you may not see the lambda sign there. Okay. So now tell me what you can see in this abdominal scan. Can you see the cervix here?
Yes.
Yes?
Yes, ma'am.
Yeah. And this placenta? Is it looking normal or is it looking little thick?
Thick.
Yeah. So where do you measure the placental thickness? Or the placental thickness corresponds to what? It corresponds to the gestational age in weeks. If this is 23 weeks, that means it will be 2.3 centimeters. Okay. So it is almost coming up to the os. And this one, this is the external os, this is the internal os. And is the placenta covering the os? Yeah, here also, do you see the placenta is thick? Yes. So now coming to the placenta previa, here the placenta is covering the internal os. So here you can see the cervix transabdominal scan. Yes. What is this black line?
Retroplacental translucent.
Yeah. So are you worried? Or are you happy seeing that?
Happy.
The two words, no? You're happy or not?
Happy.
Yeah, Hridya, you're happy or not happy?
Disruption of retroplacental.
Aparna, you're happy or not happy? If this black line is seen, you're happy or not happy, ma?
Happy.
Okay, so two people are happy, so even I'm happy seeing that. So coming to the classification, let us see, we see complete placenta previa where the placenta completely covers the internal os. In partial, the placenta partially covers the internal os. Marginal placenta previa where it reaches the os but it doesn't cover the os. In the low-lying placenta, it extends into the lower uterine segment but it doesn't reach the internal os. I want you just remember two. Okay. So if the placenta which covers the internal os and which is about 2 centimeters on the os, like if it is posterior covering the os and extending 2 centimeters above to the anterior, then it is complete placenta previa. If it is less than 2 centimeters, it is marginal. If it is more than 2 centimeters, then we call it as normal. So everything is 2 to 2, right? This. So now you tell me, I have labeled everything. This is the cervix, right? This is the internal os, and this is the placenta. Is it more than looking 2 centimeters? Yes, right. It's almost looking like on either side, it's mostly covering. Yes, complete placenta previa. So now this is the cervix, and this is about 1.3 centimeters. That means 13 millimeters is 1.3. So what do you call this placenta?
Low-lying placenta.
Yes. So here it is 2.5 centimeters. So what do you call it?
Normal placenta.
Normal. Because subjectively we might feel it is very close, but unless you see the relationship from the internal os, you should never say what kind of placenta is it. And any placenta previa, if you're suspecting, please do a transvaginal scan, make a proper measurement, and then come to the diagnosis. So when you diagnose the placenta previa in the second trimester TIFA scan, does it remains the same till delivery?
90% of the placenta previa will ascend up in the third trimester.
So what are the measurements, or when do you expect that? Because that's the time you need to counsel your patients, right? So if the placenta is covering the os and it is like more than 2 centimeters passing the os, the likelihood ratio of this placenta resolving to be normal is almost 0. So if it is more than 2 centimeters from the os, then it is going to be like, migrating to the upper uterine segment. But if it is less than 2 centimeters, 89% might resolve, but still there is about 10 to 12% still remaining to be the placenta previa. So when do you call them for the next scan? It's around 32 weeks. Even at 32 weeks, if you do still present with the low-lying placenta or close to the os, you need to reevaluate them at 36 weeks because that's the time you take the delivery decision for the patients. So tell me now.
Who's covering?
This is the bladder, and this hypoechoic line is the internal, cervical canal. And can you see this? What placenta is this? Posterior placenta, because bladder is here. So posterior placenta covering the os and going anteriorly. So this is placenta previa. And what is this you're seeing? Is the previous picture and this thing the same? Both are posterior placentas, but do you see there's large chunk of placenta is extending to the anterior segment? And what is this you're seeing? Something is moving inside the placenta, which we doesn't regularly see, right? Normal placenta, when you scan, you don't see the things moving inside the placenta and so much of blood pouring directly into the placenta. So what are these things called? I heard you telling you in your first presentation itself. Placental lacunae, yes. And can you see the cord going through the vessels here? So coming to the placenta accreta spectrum of disorders, it's very simple. If the placenta, you can tell me now, what is placenta accreta?
Reaching up to the myomectomy.
Adherent to the myomectomy.
Yes. Yes, it's increta is, you can see this picture and correlate like how it is actually invading inside or it is moving inside the myometrium. If it is up to the serosa, it is percreta. So this hypoechoic line, what we have seen is a very reassuring sign. That means it has not invaded into the myometrium because the retroplacental network of vessels is what bridges between these two. Usually when the placenta is separated, this is the area where it gets separated. And these small placental lakes are very common, but the one which we see in the video are not common. Can we see this?
Something wrong with the net.
Previous cesarean section.
Yeah.
You always
Connectivity is wrong.
should ask the patient. It's very important. You cannot interface what is happening. So when the bladder is full, we'll be, because for the TIFA, any scans in the second trimester, we always tend to ask them to empty the bladder and come. But this is one place you need to ask them to fill the bladder, wait for some time and come back. You can see this bulge, no myometrium, but bulging into the bladder. So when you switch on the color, there is hypercapillarity and there is bridging vessels, which is this is a 32-weeker. Can you see this placental lacunae? And between the bladder and the anterior wall, you can't make that is somewhere. Here you can see the myometrium. Yes? But as we go into the center, you can see the bulge and hardly there is no myometrium intervening in between the placenta and the bladder. Can you make out?
No.
The same thing, because the lacunae, they get filled with the blood, which you don't, even if you see some lacunae in normal placenta, you don't see them filled with the blood. And can you see this vessel which is perpendicular from the bladder wall? This is a typical feature of the placenta accreta spectrum.
Bridging
Okay?
vessels.
Yes, yes. You can see here also. Can you see this bladder? I have labeled the bladder wall, and you can see how they're like, you know, perpendicular. These are bridging vessels. Can you see now with the arrow where I'm pointing out, and how the lacunae are filled with the blood vessels? So this is a static picture, and this is a transvaginal scan of the same patient. You can see it's so thin. And just now in Dr. Pali's lecture, we heard, no, it is always better to do a subtotal hysterectomy. Once we start seeing the more cases, especially transvaginal, it is not only lower uterine segment, the vagina, upper vagina, parametrium, everything will be so vascular. Like even to do a vaginal scan, you get very scared. So I don't think you get any place to take a suture also, because with the obstetric background, when we do those scans, we always tell the obstetrician, like, you know, the whole of the upper vagina and the fornix, everything will be so vascular. So I think there's a reason why the rationale of doing a subtotal hysterectomy, where you get at least a pedicle to suture it. You can see here, this is the bladder and this is the lower uterine segment, and there is nothing. It's so thin and there is a lot of blood vessels there. This is one slide I added after Dr. Shekaran sir told about, can we predict a placenta accreta spectrum in the first trimester? You can see this is an NT scan. Yes, we do, because when you see an exaggerated chorionic reaction, the placenta will be big, and you can see a lot of placental lakes here. Can you see the lakes? Increased vascularity, and this is the lower uterine segment where the cesarean scar, previous cesarean scar is. Especially women with the previous cesarean scar, you need to be very, very careful. Especially sometimes we do get like more than one cesarean. That's when we always have to ask them to come with full bladder and see how thin the cesarean scar area, and you see lot of retroplacental lakes and increased vascularity at this area. You can see, right, the increased vascularity at that area. So moving to the placental abruption, as the placental abruption is very difficult to identify by scan. Two reasons, because when there is immediate bleeding, it is majority of the times it's an obstetric emergencies, because emergency doesn't give it time, and the blood, the fresh blood and the placenta appears the same, but when we put on the color, the area where there is separation, you don't pick up the color. But the clot, appearance of the clot depends upon the time of the event and the time of the scan you do. So for example, the case like this, you can see a heterogeneous mass which moves, you know, when you do the scan. This happens when the clot is organized. But when a fresh bleeding, many of the times it's very difficult. That's why the ultrasound in abruptio placenta is only 50%. So most of the time we do take decisions on the clinical basis. So can anyone tell me, this is the cervix, what is this? What is this line? What else can be there in the uterine cavity? Umbilical cord. Yes, because something which is in the membranes above the cervix between the fetal parts is, what do we call that? Vasa previa. Yes. So when we put the color, retract the probe, and you can see nicely the cord loops and the cord along with the membranes above the cervix. So anything else for the questions? Because I just wanted to be more question and answer session. I think I need to be very quick because of your dinner time also.
Yes. Yes, Dr.
Very nice, Dr. Sridevi. You covered very nicely so that I could understand also. And also, first times to scan in a previous cesarean, don't forget about the scar ectopic also.
Yes, sir.
That is another
And
problem.
thank you so much. And it's a privilege to hear such a good comment from you, sir, because we all learned hearing from you. And when you say such words, no, it's so nice to hear.
Thank you very much. Thank you. Thank
you. Can I ask a question? What is crossover sign?
Yeah, usually the vessels you are like, you know,
I would like
straight. But here they're perpendicular. I think the video shows the perpendicular passage of the vessels.
Hello.
Yes.
Hello. Dr. Sridevi, it was a very good talk. So as sir said, we also studied so many things from your talk and by seeing the pictures. And as Jyoti asked, let me ask another sign, because
Sure.
we know that in abruption there is not much the importance for the ultrasound, except in case of large hematoma you can see only. In 50% of cases of abruption, ultrasound will not help. But there is a sign called yellow sign. I don't know, I had read in the textbooks. The placenta may be jiggled when sudden pressure applied to the placenta with the transducer of the machine or fetal movement. Can you explain a little more about that?
Yes, ma'am. Because see, whenever there is separation, I think we all know how the clot looks when it is in the hand.
Yes.
Yes. When we
Yes.
move, what happens? Is it like a
Yes.
gel or not? Same, yes, the same thing you can see, but when we put on the color, there won't be any color. And when it is immediately, if when we do a scan immediately after the abruption, it will be very hyperechoic. The placenta looks big and it's very hyperechoic. It's like spots. But when little later, when we do, that's the same thing which we use in the hemorrhagic cyst. When we do the scan, we do bimanual examination, and when we do, it's like a jelly, it will move.
Yes.
Because the clot will retract, and then there is some amount of fibrin deposition, and it will try to move like a gel there.
Okay, thank you. Thank you for your answer.
Welcome, ma'am.
Thank you, Dr. Sridevi. That was wonderful.
Welcome.
Students must have gained a lot. They must have not seen these images like this. Thank you so much for all the effort. Thank you. I think you can stop sharing. So, all three of you, Hridaya is there. Aparna and Shamima Matrelo. Hridaya is not there. We've lost her. She's lost a connection. So quickly, just few viva voce questions, and we finish off. So let me share the screen. Can you see my screen? Okay, the first question goes to Shamima. This is vasopressin, okay?
Yes, ma'am.
And how much it contains, what is the unit? It is measured in unit. One vial can be a single dose vial or a multiple dose vial, okay? So the question is, what is its use in obstetrics and what is the dosage?
Vasopressin is used in obstetric, that is later before we discuss it in the placental, but if there is more bleeding, we can use vasopressin to prevent the bleeding by vasoconstriction.
Yes, so not when bleeding occurs, before you dissect. So you inject so that you get a blanching effect. And what it does is, it is also called medical tourniquet. And it has got a vasoconstrictive effects on the V1 receptors of the uterus when given locally. That's why it is given even in myomectomies. So myomectomies are not. That's because the uterus has got V1 receptors. So this goes and blocks them. So it produces a vasoconstrictive effect. And there was controversy, but there are surgeons using it in dilution. And once we dissect the bladder and placenta previa, so before dissection, you just inject. So you get a vascular field. Okay. So any side effects, Shamima?
Cortical necrosis, renal cortical necrosis.
No, the most common dreaded side effect we tell the anesthetist.
Cardiovascular, that is
happens. What happens? We tell the anesthetist that we are injecting. Once they give a signal only, then we inject.
Hypertension.
We should be looking at the monitor. Bradycardia. Bradycardia, which happens, and then you can have a tingling, numbness. The patient may complain after surgery, nausea, vomiting, sweating. Okay, so the next question goes to Aparna. It's on tranexamic acid. So you tell me, what are the indications we use tranexamic acid for?
It is used in both obstetrics as well as for gynec conditions. In obstetrics, it is mainly used to prevent, in postpartum hemorrhage, it can be used.
Prevent? You mean prevent?
Maternal death.
You said prevent postpartum hemorrhage?
No, not to prevent. As a management of postpartum hemorrhage.
Yes.
There's a gynecology. It can be used for. It is used for in menorrhagia, abnormal uterine bleeding.
Yes, very good. So now, what is the dosage?
For PPH, it is usually given in 1 gram. 1 gram dosage is given diluted in 10 ml over 10 minutes, and if the bleeding is not controlled, you can even give it after 30 minutes.
Okay. Any side effects?
Can produce thromboembolic effect. Theoretically, that side effect is usually said. DVT, pulmonary embolism.
Color blind.
Can have nausea, vomiting, diarrhea, giddiness, risk of thrombosis. Contraindications?
In history of DVT, color blindness is a contraindication.
DVT. Insufficiency in DIC, you don't use it. Okay, so the next question is for Hridaya. We have discussed this, which is covariate uterus. And you can also see that blood is seeping into the broad ligament. So what is the reason for this? There.
Abruption of placenta, and the blood has seeped into the myometrial layers.
So they can beneath the tubal serosal layer also, broad ligament also, in the substance of the ovary also, and sometimes you can find free blood in the peritoneal cavity. So all this can be present if there is a covalent change in the uterus. Okay. So we had discussed this, that it is not an indication of hysterectomy, and was also told that seldom this produces uterine atrophy. Okay, fine. So any other name for this covalent uterus?
Uteroplacental apoplexy.
It's very good. So now we'll talk about some blood products. We'll start with Chamina, fresh frozen plasma. So what are the indications for giving FFP?
If there is absence of any fibrinogen, reduced amount of fibrinogen, like in abruptio placenta, it is an indication for FFP. Or in massive transmission protocols.
The ideal one for ideal is
cryoprecipitate.
When somebody asks you what are the indications, what should you say? This is what you say. That when the patient is DIC, when there is dilutional coagulopathy, when she has some coagulation factor deficiencies like liver disease, warfarin overdosage. Warfarin overdosage you give, or TTP. Okay. Now, can you tell me some storage guidelines about FFP? How you store it?
FFP stored at -25 degrees Celsius. -35.
So you can store it for 1 year. You can store it at -35. Okay. And use before use thaw in the plastic thawing bath at 30 to 37, and then only you can use it. If you use it higher temperature, it will destroy the coagulation factor. And once it is thawed, you should use it immediately within 12 hours. Or after you have thawed it, that is, you put it in 30 to 37 degrees, then you can put it at refrigerator at 2 to 6 degrees. Okay. How much does it contain in the bag?
15 ml.
FFP. Does it look 15 ml? Looking at the bag.
200 ml. 200.
Yes, 200 to 300 ml. And what does it contain? Contains stable clotting factors, albumin and immunoglobulin. Now we come to cryoprecipitate. So how it is prepared, cryo?
It is prepared by thawing fresh frozen plasma. As a result of which all these will precipitate and then it gets refrozen.
And so you thaw the FFP and at 4 degrees and then resuspend in 10 to 12 ml of plasma. What are the contents?
It mainly contains factor 5, factor 8, von Willebrand factor, and fibrinogen.
Yes, very good. So fibrinogen 150 to 300 milligram per packet. So that is the most important factor in this hypofibrogenemia. Okay. What is the dosage?
1 unit per 10 kg.
Yes, at least 6 units to be given for an adult dose. Then what are the uses?
It's mainly used whenever there is hypofibrogenemia, which occurs when there is DLP or a dilutional coagulopathy.
It provides you a factor 8 also, so you can use it for all these conditions and definitely when it is hypofibrogenemia. Any administration guidelines for cryoprecipitate?
It also has to be administered as soon as possible. It is within 30 minutes of getting from the
6 hours of thawing, and it should be ABO incompatible. Okay, there's no need to cross match it, and after thawing transfuse as soon as possible, but within 6 hours of thawing. Now we come to RBC concentrate. What is the volume of RBC concentrates?
250 ml.
150 to 200 ml, of which most of the plasma has been removed and hematocrit is 55 to 75%. Indications?
Hemorrhage, anemia.
Hemorrhage, anemia. So replacement in anemic patients. Yes. Coming to platelet concentrate. What is the volume of platelet concentrate?
40 to 70 ml.
30 to 50 ml. Single donor platelet. And it contains about 5.5 into 10 to the power of 9 platelets. Dosage?
1 unit per 10 kg.
Yes, at least 4 to 6 units. Any storage guidelines?
stored at room
22
temperature.
to 26, 28 degrees. 22 to 24 degrees.
Yes, for 3 days to 5 days you can store, but what you have to do is constantly agitate it. So it has to be moving all the time. So agitation is important. Why do uses, indications?
Platelet count is less than 50,000.
Platelet count.
DIC.
Unless she is bleeding, we don't need to transfuse if it is 50,000 below. No?
Only if it's less than 10,000.
So if she's bleeding, then only you got to get thrombocytopenia. Then if there's platelet function defect and if there's some bone marrow failure, then you have to transfuse platelets. And precautions during infusion of platelets.
ABO incompatible, better.
You should give it through standard blood administration set. You should infuse over a period of 30 minutes. And for Rh negative fever, you should give Rh negative platelets. Okay. Thank you.
Full coverage of the blood transfusion and the very practical questions. Thank you, Dr. Jyoti, for making such effort too. Again, we have benefited not only the students, we have also revised, and thank you very much.
Thank you. So I must thank all the students and Subhash for the final use of thanks.
Thank you very much, ma'am, for this wonderful live OC session and for the whole program, ma'am. At the outset, let me thank
Subhash.
Yes, ma'am. Yes, ma'am.
Yes.
I want to
Please,
add
please,
one
madam,
point.
please.
Jyoti, your questions were very good, but it will have been better after 14th because we are having a webinar on Blood Donors Day. I want to add one point. When you are giving vasopressin, two things you should remember. One, you have to inform the anesthetist before giving it because there is chance for sudden bradycardia, as is earlier. Next thing is, when you are injecting anything, you should withdraw the syringe and see, in this case also, whether it is going into a vessel or not. So this you should take care when you are giving vasopressin. Okay, good.
So we should also take opportunity to invite all of you for the blood donation day we are observing on 14th, where Lalita because madam's daughter is going to speak on blood component therapy. So all of these people who are logged in come at 7 o'clock on Monday. Subhash.
Thank you very much, ma'am. At the outset, let me thank our president, Dr. Jyoti Chandran madam, for this program and for the beautiful YOC session. And again, I would like to thank our invited faculty, Dr. Brigadier Professor Aruna Menon madam, and also the chairperson for that session, Dr. Kunyama Roy madam and Dr. Sharma madam. And also, I would like to thank the pioneer of placenta accreta and all the surgery, the vaginal surgeries, Professor Piley sir, who had come down and taught us a lot about the surgeries and about his clamps. Again, I would like to thank our senior Professor Chekaran sir, Ambuja madam, Lalitamika madam for chairing these sessions. And also, I would like to thank the speaker of the students also who have done wonderfully well for this whole session, for the second session. Again, I would like to thank our faculty, Dr. Sridevi Veera, Sridevi Kevi, who has come all the way from Vizag and who gave a wonderful talk about the whole the ultrasound spectre. And it is so nice to hear from madam for a long time. And I would like to thank all the delegates here who have come down and all the postgraduates who have benefited immensely from this wonderful teaching program. Sapan and team, thank you very much for your wonderful co-host and for hosting the whole program. Thank you very much, one and all. Again, I would like to remind everybody that this is a concurrent program every month on second Saturday of every month, second Saturday evening at 6 p.m. Next month, we are planning to have a session on male infertility and female infertility, as Dr. Jyoti madam has suggested. So again, I would like to thank madam for that session. We'll come back with the brochure soon. So students, please do put on the message to everybody that we have a program on every Saturday, second Saturday in the evening from 6 to 9 p.m. on certain topics. Again, I would like to thank the whole postgraduate, all the three postgraduates. They've done wonderfully well, and as Dr. Shekharan sir and the team have said, they've all passed with very wonderful marks. Again, I would like to thank the whole team, Team Senora, Team Spectra, and Team Inca from the Sun for sponsoring these sessions and always being supporting for us throughout these sessions. Thank you very much, everyone. Thank you. Meet you on next.